Ganesh, we welcome you all for today's gathering.
Respected dignitaries, esteemed faculty, distinguished chairpersons, honored speakers, and dear delegates, a very warm welcome to each one of you for this exciting GI and minimal access robotic masterclass. It is truly a privilege to have such an accomplished panel and experts gathered today to share their knowledge, experience, and insights into this ever-evolving field of robotic surgery and minimal access surgery. Today's academic sessions promise to be enriching, thought-provoking, and filled with practical learning that will benefit surgeons at every stage of their career. Without further delay, let us begin our scientific program. For today's session 1, to begin the evening, we have a topic that forms the foundation for anyone stepping into robotic surgery. It gives me immense pleasure to invite Dr. Shashikiran Bedi to deliver his talk on robotic surgery for beginners. May I also request our respected chairpersons to kindly grace the dais. May I request Dr. Sunil K.R., President of Surgical Society of Bangalore, Dr. Vikram B., Secretary of Surgical Society of Bangalore, Dr. Harish, President-elect of Surgical Society of Bangalore, Dr. Wasim, Consultant of Surgery at Manipal Hospitals, and Dr. Sunil Joshi, Professor and HOD, Nandi Medical College, Chikbalapur. Thank you. May I invite Dr. Shashikiran Bedi to deliver his talk.
So good evening, everyone. So my name is Dr. Shashikiran. So let us try to understand why we talk so much about robotic surgery, who should be starting the robotic surgery program, and what are the advantages we have about robot. So why robotics? So it's been a long journey. So initially we all started with open surgery. So then laparoscopic surgery was accepted after some skepticism. Then we have robotic assisted surgery. There is always, that debate has always been there, whether lap is good, robotic is good. What all cases can be done via robotic surgery? What are the advantages of using robotic surgery over laparoscopic surgery? Because we have spent so many years learning laparoscopic surgery throughout our MS days and our MCH days. And suddenly a new system has come in wherein the whole market is forcing us to use robotic surgery. Patients are asking for robotic surgery. So should we understand, should we accept it, or should we continue doing what is laparoscopic surgery? So that will be the topic today. So what is this robotic surgery? So the common myth is that robot operates. It doesn't. So it has 0% autonomy. So it's a surgeon-controlled telemanipulator. So surgeon's hand controls everything. It is just the robotic arms that are inside the patient's body, just like laparoscopic instruments. So basic definitions. So we don't do a robotic surgery as such. The correct terminology would be a robotic assisted surgery, wherein it's a master-slave concept, wherein we are controlling all the movements of the robotic arms. So it has 3 core components. So just the basics of robotic surgery. So we have a surgeon console. So it will be at in the operating room at one side. So wherein surgeon sits and controls the robotic arms which will be inside the patient's body. So normal ports are put just as is done in laparoscopic procedure, and the robotic arms will be inside the patient's body. And then we have a vision card. So these are the 3 main components of a robotic assisted surgery program. So this is the pictorial representation of what exactly happens in a robotic surgery operation theater. So why surgeons are adopting this robotic platform? So the main advantage, the first and foremost, is a high definition vision. So we get a 3D vision. So it's like me seeing the patient directly as is done in open surgery, but done via minimally invasive technique. Then we have end-of-wrist instruments. So the instruments are moving in all directions, just like my hand moves. So then we have tremor filtration and motion scaling. So this is one of the main reasons as why people are accepting robotic surgery. And it has also been propagated that because of robotic surgery, the surgeon's span of operating, some people would retire at 60 years, now people are saying that he will operate till 70 years just because the robotic system has come in. And improved ergonomics. So as surgeons, we all know, operating sometimes in standing in some weird positions, like especially while doing inguinal hernias and all. So we need to stretch a bit, we need to turn around, we need to twist. So that part is completely nullified by robotic surgery, wherein we are just sitting at surgeon console and operating. So enhanced access in confined spaces, especially in pelvis, male pelvis, while doing rectal cancers and all, robotic system is definitely helpful. And then we have a shorter learning curve. So as we all know, while doing laparoscopic surgery, just suturing with laparoscopy takes a lot of years together. First we hold the camera, so that is for many years. Then we start assisting, then we start operating. So it's been a long curve. So with robotic surgery, that curve is shortened a bit. So this is the high definition vision that we get because of this lens. It's a 3D lens, and we get a magnification of into 10 times. So the other advantages are, one is filtering of the hand tremor. So it definitely increases the surgeon's longevity of operating. So then we have end-of-wrist movements wherein there is 7 degrees of freedom. So this is the typical difference between a laparoscopic instrument and a robotic instrument. So 7 degrees of freedom as I was doing. So compared to traditional laparoscopic surgeries, the dexterity is improved by 65%, reduces skill-based errors by 93%, and reduces time to task completion by 40%. So as any procedure, so definitely it will have some cons also as when compared to its pros. The cons being high capital and consumable costs. So initially to set up a robot, one thing is the high cost and the repeated utility of the consumable. So that will keep on increasing. So that can only be nullified by increasing the number of cases we do. So whenever we start a robotic program in a hospital, if a plan is to set up a robotic program, it cannot be just one surgical system operating on it. So it should be a team of doctors like gynecologists, urologists, surgical gastroenterologists, general surgeons. So everybody should be operating, and cardiothoracic surgeons. So all the systems, all the units in the hospital need to operate, then only this can be nullified. Then the next thing is absence of true haptic feedback. So whenever we touch a tissue, so something called haptic feedback is there. Whenever we are touching with hands, we have a high haptic feedback. With laparoscopic instruments, it is reduced a bit, but definitely it is there. With robotic system, that system is gone. So basically, we need to rely on the 3D vision and the high definition vision that we get. So in that way, we'll be able to nullify this con of the robotic systems. Then docking and setup takes time. Initially to start with, yes, but as the number of cases which you do increases, and as your OT staff tend to get accustomed to it, the time that is required for all these things will start decreasing. So larger footprint, so smaller OTs and all, it's very difficult to set up a robotic system there. And steep learning curve, but as compared to laparoscopic procedures, definitely the learning curve is a bit less. So we have different robotic systems that are gradually evolving over time. So this is an indirect validation that robotics is the future. So many companies are investing billions of dollars into this system. It automatically implies that robot is here to stay. So then let us talk about the applicability of robotic systems in surgical gastroenterology and minimal access surgery. So it can be applied to all the systems, starting from gallbladder till rectum. So when we are starting the robotic system, so we need to be very careful in choosing the cases. So first and foremost, we have to start with simple cases. The classical simple case would be a elective cholecystectomy. So many a times surgeons keep telling, why does we require to operate, take a robot for cholecystectomy? It's a simple procedure. Before you guys docking, we'll do the laparoscopic cholecystectomy. That will be the normal argument that people give. For example, if I want to do a rectum, if I want to do a pancreas in robot, I cannot directly go and operate on a pancreas to start with. So I need to be well versed with the system. And having said this, there are so many trials which have compared robotic cholecystectomies, robotic hernias with laparoscopy. It has been found that the incidence of pain is a bit less with robotic systems. So definitely we can and we have to start with simple cases. And most of the times patients do benefit with these approaches. So we start with patient positioning. So this is the setup of the OR. So patient positioning, then port placement, similar to laparoscopy, and docking the patient. This is one aspect which takes a bit more time as compared to in laparoscopic procedures. So this is just an example of as how the procedure is done. So how many cases to proficiency? So for simple procedures, 15 to 25 cases is sufficient. For a bit advanced cases like colorectal diseases and all, 25 to 40 cases needs to be done. And for major reconstructive procedures, so one is resection, one is reconstruction, for this, a minimum of at least 40 to 50 cases needs to be done. So how do I become a robotic surgeon? So there are multiple steps because I'm doing a very good laparoscopic surgery. I cannot go sit on the console and start operating from next day. So it's basically a sequential events that need to be done before you can start operating independently on the robotic system. First is didactic and online modules, wherein you try to understand what are the components of robotic system and how it works. Then we have virtual reality simulator training programs. Then we have dry lab programs. Then bedside assistant role. And when you are well versed with all these things, eventually you will be certified as a robotic surgeon. So most important thing for the beginners is when to stop. As is always told in surgery, a surgeon should know when not to operate rather than know when to operate. In a similar way, when you're starting with the robotic program, you should have a very low threshold to convert it to laparoscopic or open procedure. There is no harm for a beginner, and we have also done that. It's not that we have always been able to do robotic surgeries in all the cases. So if at all, if there is some issue, we should at least in the beginning of our career, so it's better to convert whenever you're feeling it's getting prolonged or there is more of blood loss. So the most important thing you have to keep in mind is, I can always convert. So conversion is not failure of surgery. So coming to the difference, so whenever there is a new procedure, so we always compare it with the existing gold standard and try to say that it is non-inferior. Once we do that, then we can start talking about the advantages of the new technique, that is the robotic procedure. So oncological outcomes, it's non-inferior, it's always comparable, and in some cases, definitely advantages in terms of blood loss, in terms of the lymph node yield and all. Short-term outcomes, yes, definitely robotic has better advantages than laparoscopic because the length of stay is a bit less with robotic procedures, and also the incidence of reoperation in major cases is also less with robotic procedures. Cost and operative time, most of the times robotic has a higher cost, and operative time, as the number of cases in the institute increases, the operative time correspondingly starts decreasing, and at some point the operating time will becomes the same as a laparoscopic procedure. So in India, what exactly is happening with robotic procedures? So there has been rapid growth in the robotic GI procedures. Over these 5 years, so many institutes have started buying up, and also new systems have come into the system wherein, like SSI Mantra, which is Indian made. So many hospitals are installing these things, and robot is the future. At some point of time, probably 5 years down the lane, so most of the hospitals will be having robotic systems once the cost comes down. So with our experience, so how did we start this robotic program and where we are as of now? So we, again, as I told you, we all started with robotic cholecystectomy, and initially we chose simple cases of robotic cholecystectomies. So the role of robotic assisted cholecystectomy, as I was telling, factually it's very difficult to differentiate and take an advantage out of robotic system as compared to laparoscopic procedures, because laparoscopic cholecystectomy is the gold standard. But as I told, if you have to do complex procedures, you have to do with simple procedures, get confident with the movement of the instruments and all, and if there is blood loss, how to control these things, and then you can take this idea and build on major cases. So this is one of the cases wherein it was a difficult gallbladder. So one more thing is ICG can be used, and with ICG we can detect the cystic duct and accordingly do the surgery. So then comes robotic hernia repair. So this is also a basic surgery. So beginners can always start with these kind of procedures wherein the rate of complication, even if something goes wrong, is a bit less. So hernia is one such example wherein the suturing skills will improve, the dissection skills will improve with robotic system. So as has been told, one of the main reasons for pain, post-operative pain in hernia patients is penetrating mesh fixation, wherein we use tackers to fix the mesh. So in these cases, because of the robotic dexterity, the suturing can be used and we can fix the mesh to the pubic tubercle, and it is the post-operative pain incidence has been found a bit less as when compared to laparoscopic procedures. So this is the hernia dissection that's been done. As can be seen, the robotic instrument, the suturing is very easy. So that's why so many gynecologists also like robotic system, because with laparoscopy, suturing is so difficult. With robotic instruments, it becomes very easy for them. But the main problem with us is, especially general surgeons and surgical gastroenterologists, is that we are well versed with laparoscopic procedures. So if you ask me, I can do any kind of laparoscopic suturing. So why should I adopt this robotic system? So the next thing is, whatever evolutions that will happen, so the AI is coming up in a big, big way. So whatever changes that will happen on the robotic system. So most of the AI integration, for example, automation can happen. So they might detect the blood vessels that can be easily seen on the screen. So all these things, whatever developments that will happen on the robotic system. So when these developments happen, I cannot say that, this development has happened, I will run robotic systems. So that's not the way. So I'll be ready for whatever is coming up. So you have to evolve and you have to understand and you have to start using robotic system. So this is robotic incisional hernia repair. So then coming to the gastrointestinal cancer. So main important thing is the lymph node yields. So that can be definitely increased with robotic system because we have a good precise 3D system and a good dissection technique because of the movements. Then we have endostaplers. So these endostaplers, they assess the amount of pressure that needs to be applied while putting staplers. So definitely the incidence of bleeding is a bit less as when compared to laparoscopic procedures. So especially in bariatric surgeries and all, robotic system is very easy to do. Then some studies wherein the post-injury, bile duct injury procedures have been very well documented and they have established that the robotic system is the way forward. Then for the esophagus also, since it's a confined space, especially for pelvis and esophagus, robotic systems definitely have advantage over laparoscopic system. So again, so as you can see in the diagram, the thoracic duct can be easily identified with robotic system and can be ligated so that injury is minimized. And also we can see the vagus branches supplying the bronchus. So accordingly, we can avoid it and prevent incidence of postoperative pneumonia and all. So anatomical detail, especially, is pretty decent with robotic surgery as when compared to laparoscopic procedures. Robotic surgery for colorectal cancer, again the same thing. So the incidence of the high lymph nodes is pretty high, and also the blood vessel, this one is also very high. The blood loss is also very less with robotic systems. So 5 things to remember. The robotic surgery is surgeon-controlled telemanipulation. There is no autonomy involved here. It offers 3D vision, registered instruments, and ergonomic benefit over laparoscopy. So most important thing is case selection and structured training. Surgical principles, they remain the same. So be it open, be it laparoscopy, be it robotic, surgical principles remain the same. It's just the way we approach it. Know your emergency conversion pathway before every case. So that is the most important that needs to be kept in mind when we start a robotic program. Thank you.
Hi, Shashi.
Questions?
Yeah, any questions from the floor, please? Yes.
So thank you very much, sir. That was a wonderful talk.
Thank you, sir.
This robotic surgery has come as a revolution in the medical field. I have 1 or 2 simple basic questions. There are 3 things. One is availability. 3 A's: availability, acceptability, and affordability. 3 A's:
Yes, sir.
availability, acceptability, and affordability. Acceptability, technique-wise, it becomes simpler, acceptable by most of the patients. Availability, I don't know, you know it better, how many hospitals can do it. And third one is affordability. My point is, a simple surgery like gallbladder surgery or say inguinal hernia surgery, which can be easily done. See, this regular surgery has become outdated, whereas laparoscopic surgery has been there for decades. It can give results as good as robotic surgery.
True.
So in such a scenario, are we justified in, I don't want to use the word marketing, pushing the patient towards robotic surgery? And another, in the same question, the robotic surgery, is it the surgeon's choice or the patient's choice? Because surgeon, as a robotic surgeon, for you it is your choice. As a poor patient like me, I prefer going for a lap surgery.
True.
What is your comment?
Sir, basically in India we have all kinds of populations. So we offer robotic surgery to people who are affordable, like we work in corporate hospital. So if I go to my native place, I cannot offer robotic surgery for them when it's not available and patients might not be affordable. So that's always there. So having said this, if it's a complex surgery, for example, the same debate would have arisen some 30 years back when laparoscopic surgery would have come in. So laparoscopic surgery is costlier than open surgery. And if we are talking about cancers, cancer treatment is more important than a big scar or not. So that would have been the debate at that point of time. And now, sir, you are talking that laparoscopy is better than open. You gave that this one. So in years to come, and that will not be 20 years, sir. 5 years down the lane, the cost will come down for sure for robotic systems. And as we surgeons increase the number of cases, the results will also improve. And as you told, for gallbladder and hernia, so it's most of the times it is insurance patients who come to our corporate hospital. So that's why we offer them robotic surgery, and definitely with hernia, we have that advantage over laparoscopic surgery. So if the patient is not affordable, if I was working in a government setup, definitely I would not offer that surgery to him. If I think that robot is definitely going to benefit, for example, if it were to be rectal cancer or an esophageal cancer or a pancreatic malignancy, then definitely I will offer, because cost comes second. First thing is patient benefit. So if I think if I can benefit the patient by offering him robotic surgery, definitely I will offer, sir. Cost is secondary. I should not be thinking about cost.
To what extent the cost increases in a robotic surgery?
It depends, sir. Most of the times it is around 1 to 1.2 lakhs more than the traditional laparoscopy procedure.
Is it covered by the insurance?
Yes,
also?
sir.
Insurance.
Sir. Many insurances cover it. Some insurances give about 50%. It depends, sir. If it's a high volume center doing a lot of robotic surgeries, then most of the times the insurances give clearance, sir.
So, is it this robotic surgeries, any published evidences have come up? Because it is a recent advance.
No, sir. Well, there are so many research studies on robotic surgery. We have RCTs on robotic surgery showing that robotic surgery is better.
In the PubMed, is it available?
Yes, sir.
All
Yes,
the
sir.
articles.
PubMed, sir. PubMed. It's been there from 15-20 years, sir.
Okay.
Sir.
Any more questions? Yeah. Mike, please.
Yes, sir.
So if you look at Rubina,
Yes, sir.
4K, if you do the ICG and overlay mode, you can have ICG mode plus the white light mode also.
True.
But that may not be the same with
No, it's not there,
robotics.
sir.
So then that disadvantage comes into picture.
Sir. See, again, if you start comparing one points, definitely at some point even open surgery will win over laparoscopic and robotic surgery. And we cannot say that open surgery is better than robotic or lap. This is an added advantage we have, that the ICG green can be used. Not all laparoscopic systems have ICG. At least all Da Vinci's have ICG. And that overlay mode, as we talk, it's in progress, and probably in some few generations it might come up. So that is one disadvantage that definitely there with robotic systems as when compared to the latest advanced laparoscopic procedure.
Hi, sir. I'm Dr. Saurabh Mishra. I'm the director of the Minimal Access and Robotic in Fortis Hospital. So I want to answer your question, sir. So about 3 days ago, there was an article which has been published in the Endoscopic Journal, which is, the authors are from Delhi. They are Dr. Andeep Vedaman Etle, and they have published a multi-center trial. And in all the parameters where blood loss, pain relief, and faster recovery is documented now as a plus point for the robotic procedure. Thank you. Just my
Yeah, Dr. Shashi, I just want to know, suppose there is an equipment failure. Have you come across equipment failure?
Acute?
Equipment failure. It's an equipment, right? Robo failure. On table, have you come across
I got
any
that
such
part.
way?
No, sir, till now we haven't had that kind of an issue here.
But if it happens and if you have only one, then you'll have to convert to either lap or
Yeah,
open.
definitely, sir. Anyway, we have two systems in.
But any
if
such
that-
studies
if
have you
that
come
happens-
across?
No, sir. Of late. I
So
haven't.
you think it's the perfect system?
No, sir, definitely. As a system, as it olds, probably ours is 8-9 years old. Probably 15-20 years down the lane, if you are using the same system, that might happen. So there is no harm in converting it to open. Patient safety takes the priority always.
So as I can see the discussions here, the change is constant, right? The change is constant. So we've been looking at open procedures, then laparoscopic. There was so much of an obstacle or, negative thoughts about laparoscopic surgery. And today there's no surgeon, I think, who can say laparoscopy does not have a superiority over open surgeries. So in the days to come, probably I think we have to be critical. We have to be critical, as many points have been mentioned there. But we have to be open to the ideas.
True, sir.
So I see that you've already done about 3,000 cases. 3,000 cases
At the whole institute, yes, sir.
all over. And also the key is that all the specialties should chip in
True, sir.
and start doing the procedures, because it's not possible for only one specialty or a department to go ahead and achieve this kind of a
True, sir.
milestone. And especially since there are different specialties that can work together, that is one thing that I want. And then second thing you said about the training program. Of course, I understand that there are hardly, how many hospitals have robotics, and I'm sure everybody is interested. but the practicability and feasibility, affordability. 3 A's, as sir said, is a wonderful thing. Affordability, acceptability, and what was the other thing, sir?
Affordability.
Yeah, affordability. So in the days to come, probably when you do operate so many cases, probably the cost will come down, and the devices also. What is the cost of Da Vinci and when it started, and how is it now, and what is SAS Mantra coming
Sir,
down with?
Da
I think
Vinci-
this is just an
Da Vinci is around 12 to 15 crores. Now the next version DV5 is coming. That will be priced at around 25 crores, I think.
Okay, so that's going higher up. We are talking about bringing it down. Okay, what about
But
our Indian
eventually it
counterpart
will
doing?
happen, sir.
With the numbers, probably we'll be able to compensate,
happen.
isn't it? Laparoscopic equipments are also a big asset when you wanted to buy them and bring them together. Have a ICG, have a 4K camera, and all that. It was an expense.
Imagine when computers were launched, it was the same thing.
Yes.
So things will change, and things are changing at a higher rate than it was changing previously. So open to lab would have taken 20 years. I think lab to robot might take a bit less than 20 years.
Yes,
is what I
of
think.
course. The older generation of mobile phones took longer time to
sir.
get updated, and then it's very fast these days. So it's quite logical. As the technology advances, the things will be progressing faster.
So maybe
Doctor,
out of the way.
questions.
Maybe out of the way.
Yes, sir.
The thing is, as far as the HCG is concerned, digital pathology has already advanced. The thing is, with the application of robotics, is there any probability of applying on the spot, on the table?
It will eventually at some point of-
diagnosis, especially histopathological, is there any feasibility? I mean,
It might happen.
maybe out of the way.
It's completely out of this one, but it might happen. So
Because histopathology, now digital pathology has come already. We need not wait for the data memorial. On the spot itself, we can make such
sir,
kind of
definitely that will be included. If you ask me, at some point of time, it will happen.
Yeah.
It's just matter of time.
In your talk, that word was there, with the application of artificial intelligence.
Sir. In
is
that
this
way,
kind-
what's happening is probably 5 years down the lane or 10 years down the lane, autonomy might happen. As in, you can mark the stitches, mark the places where the robot is supposed to take stitches, and will start taking stitches. So that's in the card. That's gonna happen. And at some point, the blood vessel, the vascularity, and all those things without using ICG green. So the AI probably they might include all those things in the system, and you never know, sir. Because if you ask me 20 years before, for all the surgeons, if someone had told the concept of robotic surgery, he would have laughed at it. Then the robotic system came in, and it's come up in a big way. So the technology changes, we never know. It will happen. We need to just keep evolving with the changes. That's also.
So there are a few cases like complex oncosurgery, cardiac surgery, neurosurgery. Are there any limitations where robotic surgery is not possible?
Sir, definitely, if the adhesions or if it's a big tumor, there is not much space inside the abdomen, definitely open surgery is the way forward. So that needs to be individualized. It all depends on the surgeon's expertise, surgeon's experience. In that way, they should take it by individually, according to the case, sir.
Okay, so the lady has a question here. Madam, can you?
So we were talking about equipment failure. So in one of the conferences, Dr. Randeep Wadhawan was operating, and all of a sudden the display went blank. And of course, it rebooted immediately. All we had to do was switch the thing off, and then it came back by itself. So my question to him after that was, let's say there is a bleeder, and it shuts off like that, and the screen is completely black. What do we do at that time?
So that can happen with laparoscopy.
Yes, it can happen anywhere. So I was just trying to tell him that at that moment, sir said that the moment you see it, in that fraction of a second, if you can put your instrument and hold it,
That's
just
logical.
before it happens,
That's logical, huh?
and then you come, apparently the instruments don't move. Once that happens, whatever you're holding, that vessel, apparently it doesn't move. So that way your equipment slightly, I think, supports.
In Da Vinci, there is this fail check mechanism wherein at least you can remove the instruments. They don't get stuck there.
Yes, but if you have a bleeder, sir, and then
So,
it goes
see,
off.
what would you
then-
do otherwise?
Ifs and buts can
Doctor,
happen.
what would you do otherwise in case of a laparoscopic surgery?
would you do?
Suppose there's a equipment failure. What would you do?
You'll open up. Huh?
Yeah, you are mentioning probably if you cannot see, at least you can approximately
Yeah,
hold the area.
Yeah.
To come to aid of Shashi, most of the laparoscopic surgery will have a already scrubbed in surgeon who's assistant, who will usually have a laparoscopic arm.
True.
So he will take care. He has no power of robot over him. So he can approximately hold, and he's also always seeing, he has a screen for himself, so even if robot doesn't move, he can hold for a while, and then the
And then
crisis
once it works
management can
again.
be done. Yes,
All right.
yes.
Thank you so much.
That's always true, sir.
Thank you. Wonderful questions. Thank you.
Thank you all.
Thank you, Dr. Shashikiran, for that insightful presentation. Every auspicious beginning is marked by lighting a ceremonial lamp. So may I request our esteemed dignitaries to kindly come forward, grace the occasion by lighting the ceremonial lamp. I would request Dr. Sunil Kumar, Dr. Vikram B., Dr. Harish, Dr. Sunil Joshi, Dr. Wasim, Dr. Naz, Dr. Saurabh Mishra, Dr. Shashikiran, and Dr. Manish Joshi to please come over the dais and light the lamp. Thank you. I request Dr. Manish Joshi and Dr. Saurabh Mishra to present the momentum to our dignitaries.
Just a small reminder that today and tomorrow, everything is about robotic surgery. There'll be a lot of chances to ask questions, see the different types of discussions, and most of your questions will be answered. So let us go with the flow of the sessions. And yes, please ask appropriate questions wherever necessary. But we are going to probably answer all related to robotics, especially what we have experienced in our journey. Thank you.
Our next session promises to be both educational and engaging. It's time for a debate that addresses a question frequently encountered in surgical practices, robotic versus laparoscopic cholecystectomy. Speaking for robotic surgery, Dr. Rajesh, BM, and speaking for laparoscopic surgery, Dr. Sunil KR, sir. Moderating this stimulating discussion are Dr. Manish Joshi, consultant surgical gastroenterologist, Dr. Naz Sheikh, Dr. Venkatesh KL, professor and HOD of Victoria Hospital. Thank you.
Before we begin the debate, how many of you are surgeons here in the audience? Thank you. Thank you for that. How many of you are doing lap colis? And I'll just take a vote. How many of you, and this is before the debate begins because they are going to bring interesting nuances to the debate. And this is a very simple and very sometimes silly question. Is robotic surgery good for cholecystectomy, or laparoscopic cholecystectomy is enough? So how many in the audience currently think that laparoscopic cholecystectomy is better and best? There's only a handful. Most of you are converted to robotic surgery after the first talk itself. So after the first talk itself, you have converted to robotic surgery. Okay, how many of you believe that robotic surgery is currently, as of today, August 1st, 2026, good or better for cholecystectomy? Okay, so we have 1/3 who are for lap chole, 1/3 who are for robotic chole, and 1/3 who are not ready to lift their hand. Okay, so we'll talk about this again, but let's look at how they are presenting. Are you going first, Dr. Rajesh? Yes, sir. Okay, so Dr. Rajesh is going to talk about why robotic chole is superior, and then we'll have Dr. Sunil talking about why laparoscopic cholecystectomy is still so far by far the best.
Good evening, one and all. I'm Dr. Rajesh BM, consultant surgical gastroenterologist. Actually, the topic is robotic versus lap cholecystectomy. Since both are minimally invasive procedures, the question arises, what is there to debate? My colleague Dr. Shashikaran has already made my talk easy by saying most of the things in his talk about all the advantages of the robotic. So I'll be sticking on mostly to the technique of robotic cholecystectomy and the advantages of robotic cholecystectomy over the laparoscopic one. In the early 1990s, when the laparoscopic cholecystectomy was introduced, it was met with a lot of resistance and criticisms due to the high cost, the technical challenges, and the safety profile. And over years, what happened, gradually the system got adapted and all the barriers were crossed, and it became a gold standard procedure for cholecystectomy. So 3 decades down the line, in the era of artificial intelligence and the technological revolution, so even the robotic cholecystectomy has met with skepticism in the initial phases, even among the surgical community, as we discussed earlier. So beyond understandable concerns of increased cost, and some studies and surgeons having claimed that robotic cholecystectomy is associated with higher complication rate than the laparoscopic cholecystectomy. In spite of all these claims, the robotic cholecystectomy is here to stay, and in future, it might become a gold standard at some point of time, maybe 5 years or 10 years. So coming to the advantages, I'm specifically restricting to particularly to the gallbladder cholecystectomy case. So the robotic cholecystectomy has got several advantages in selected and even in complex cases. Its enhanced precision with 7 degrees of freedom gives a finer dissection in the Callo's triangle and hepatocystic area. And the vision platform provided, that is 3-dimensional high definition vision, provides superior depth perception compared with conventional laparoscopic technique. And it is a better ergonomic platform for the surgeon, reducing the fatigue and technically in long and technically demanding procedures. The improved dexterity with tremor filtration adds to the precise dissection and fine tissue handling while operating. The other point is it gives us a better visualization of the critical anatomy, especially in the gallbladder surgery, where the safe identification of the cystic duct and cystic artery and identification of the bile duct is very, very vital. And even in difficult, some surgeons and studies say that it is not going to be beneficial in difficult gallbladders, considering the time it takes and the adhesions and other inflammatory pathology being there. But the studies have proven that even in difficult gallbladders, it can be advantageous to release the dense adhesions in obese patients and where there are dense inflammation, like in Mirizi syndrome and chronic cholecystitis. And it is even the conversion rate to open of last few years has been very low in the robotic platform compared to the laparoscopy. The other advantages, as already explained, were or reduced post-operative pain, fast recovery, and shorter hospital stay. Sometimes the patients getting discharged even within 24 hours. Certain other technical advantages which has been already explained are the stable surgeon controlled camera, eliminating the dependence on the camera assistant which is required in laparoscopic surgery. The superior suturing capability, especially useful when operating in a difficult gallbladder where we do subtotal cholecystectomy and need to suture the stump. And by rare chance when we unknowingly injure the bile duct, the repair will be very superior in robotic platform. The other added advantage with the robotic platform, in particularly the gallbladder surgery, is the usage of infrared fluorescence imaging that is called as Firefly. So it reveals the real-time biliary anatomy in the area of the hepatocystic triangle. It delineates cystic duct, the common bile duct, and any aberrant anomaly. And it also has got improved access in obese patients where it is difficult, comparatively difficult in laparoscopic surgery due to better instrument reach and articulation of the robotic instruments. Of course, few limitations which has already been discussed. I'm not going for that. So the potential clinical benefits of robotic cholecystectomy are lower conversion to open surgery in difficult gallbladders, more precise dissection with less tissue trauma, reduce surgeon fatigue, easy management of acute cholecystitis, Mirizi syndrome, or in patients those who have got dense adhesions. So I'll be straight away moving to the few videos which we have done. So this is the case of symptomatic gallbladder disease which is taken up for robotic cholecystectomy. Here you can see the precision with which the dissection is carried out and the dexterity of the instruments used. The cystic artery is skeletonized, isolated, and dissected, and then the posterior dissection is carried out and the cystic duct was dissected. So as expected, the bleeding is also relatively less. And the right hand, I'm using the monopolar scissor, and the left hand, the fenestrated bipolar is used to retract the fundus of the infundibulum of the gallbladder, and the fundus is being retracted by the clip applicator. The artery is clipped. And after clipping the artery, the cystic duct was skeletonized further anteriorly and posteriorly. So we can see the ease with which the instruments can be manipulated. And here we noticed an aberrant artery arising from the right hepatic artery, suspicious of a Moynihan's hump. So this was clearly visible with robotic platform, and we dissected the gallbladder away from the artery. As Dr. Shashikiran was mentioning, even for beginners, the robotic cholecystectomy is go-to surgery before performing any complex colorectal or the transhiatal surgeries. Once the cystic duct is skeletonized completely, and we could see the clear space and the cystic duct entering, the structure entering only the gallbladder, confirming that we have applied the clips. So the aberrant artery which we saw was found to be entering the hepatic parenchyma, probably to segment 5, and here we can see that artery was separated, dissected off the gallbladder, and the gallbladder was dissected at the fundus. So this shows that even simple gallbladders can be tackled easily with robotic platform, provided the cost is not an issue. And the gallbladder is dissected off and put it into an endo bag and taken out. So this is another case in a female with moderately obese patient with COPD, CLD, cardiac issues, everything, who presented to us with symptomatic gallstone disease. So when we inserted the camera, we confirmed that the patient had frank cirrhosis. Fortunately, she did not have any collaterals around the gallbladder or in the duodenal area. So here we are, the same instruments were used. The gallbladder is retracted and the posterior dissection was done. And the precision with which the tissue can be handled is very good with robotic instruments. As we approached towards the cystic duct, we started to encounter minimal bleeding, which was tackled without any assistance of other instruments. So here we are dissecting near the cystic duct. Because the gallbladder was very fragile, it got opened up, fortunately away from the cystic duct area. And we put an accessory port in between the arm 3 and 4, and we sucked out and gave lavage to make the field clear. And we divided at the level of the opening of the cystic duct and divided the cystic duct after dissecting the gallbladder from the bed. We have placed it inside an endo bag, and the stump which was remaining was closed with suturing, and this is where the robotic platform is more convenient in taking up the sutures. Even at this depth near the hilum. So the stump was closed with Vicryl sutures. And the drain was kept. And so summarizing, the robotic cholecystectomy provides excellent visualization and superior instrument dexterity with enhanced precision, improved surgeon ergonomics, making it particularly beneficial in complex gallbladder surgery. Though for routine uncomplicated cases, the outcomes are generally comparable to conventional lap cholecystectomy, but the robot approach, as discussed, incurs higher cost. Thank you, one and all.
Thank you, sir. Now I call upon Sunil, professor at Bangalore Medical College. We call him the AI surgeon. He is recognized at the ASI level. He is doing a lot of bariatric surgery, all that. And recently we had one robotic. So you see, all this Da Vinci had a patent for so many decades. So no other robotics, even though they were ready to release, because of Da Vinci's patent thing, they were not coming. Now plenty of companies are coming, say SS Mantra. Sunil, what did we had in our Johnson & Johnson? Some robotic fellow came, na? Electronic City.
Which one?
You did workshop for the robotics recently, BMCRI. Huh?
That is simulator.
Simulation center.
Yeah, simulator. Articulus.
RT?
Articulus.
Articulus. See, he's also a robotic company.
Yeah.
Yeah. There are so many things are coming. And robotics, as some people were asking, it is nothing new. It's as good as 2-3 decades old, 3-4 decades old. It's as old as laparoscopy. And the learning curve is less than the laparoscopy. There are so many advantages, except the cost factor. Even the, okay. So then you start. Yeah. Even BMCRI has got robo.
Yeah. Good evening to all. So I can just tell that's all, Your Honor. Because most of the points, the crowd is with me. Though you're all in front of me, I have all your support behind me. So with that support, I'll start. So this being a robotic CME, I was the only person who was talking against robots. So I came prepared for a war. But then I saw it was a gliding through. So good for me. So we all discussed in the last two talks that it is gold standard against which the robotic is being compared. The gold standard is laparoscopic cholecystectomy for any gallbladder disease as of now. So if the gold standard is being questioned, that means there should be substantial evidence, substantial amount of evidence, a lot of studies for any newcomer which should change the upper quadrant surgery. So already introduction has been done, so I won't go in that part. So we'll straight away go to the debate. So we have nail cutters, we have axe, pickaxe, swords, katayama sword. So we can cut by anything. It is a sharp instrument, it cuts. Do you really want an axe to cut a nail? That is the question. We can cut, yes. If we don't have a nail cutter, we have something sharp instrument, we can cut. We can even, cut. But nail cutter is the instrument. So what we are talking here is, should we use crores of rupees for doing an entry-level laparoscopic surgery? Open, when the time was for open surgery, cholecystectomy was an advanced surgery. Usually the PG would be given in cholecystectomy in second or third year, not the first year surgery at all. But laparoscopic cholecystectomy is the first surgery which usually entry-level amateur, postgraduate or a laparoscopic surgeon will do. Apart from that, obviously appendicectomy is there. Appendicectomy and cholecystectomy are the basic surgeries. And if you start asking the young surgeons, how many of them know suturing? Well, most of the hands, means I don't see much of junior crowd here, so I won't ask for that vote. See, most of you might be suturing, but most of the younger crowd will not be very comfortable raising their hands for suturing, laparoscopic suturing. But still they are doing laparoscopic cholecystectomy. If you are doing a laparoscopic cholecystectomy, every hand goes up. So what happens if they get into trouble? Most of them will ask for help or convert for open. That is their answer usually. So here we are comfortable with robotic suturing. Yes, I know. But for that, should we already, Shashi has told, 25 crores for an extra ease of suturing. Is it required? That is the basic question here. We all have this picture. I need not tell anything about the picture. Most of the houses have treadmill or a cross trainer or a walker or a cycle. After a few months, they are mostly used for hanging the clothes, drying the clothes. Sometimes, tomorrow morning you want to have this shirt, you can hang there so that you can easily see. We all know that. How many of you are dedicated users of treadmill? I don't think anybody can tell with a hand on heart that I'm using treadmill from 10 years. I don't think it happens. So is it happening like that? Means most of the corporates, though, they definitely have robo by this time. Most of the hospitals, in the name of marketing, they're buying robos. Are they really using robos? Because they don't have a robotic surgeon. And as Shashi rightly told, it's not a robotic surgeon who matters, it's a team. Only one robotic surgeon will not do anything. He cannot do anything. It needs a technician, a trained technician, well-trained nurse, a well-trained team. Only nurse, surgeon, technician will not do a robotic surgery. So it needs a full team. So after few, and you know Bangalore now, it is just like software companies. Each conference you meet, they will introduce in a different hospital name. So, yeah, I left that hospital, I'm in this hospital. Because of, means I don't want to tell the reasons, but anyway, everybody knows. Each conference we meet, I will ask many of them, sir, now you are working in which hospital? Because I don't know, they might have changed. So the team attrition rate is very high nowadays in metros. So obviously the team building is also a little different. So it becomes a constraint for usage of such a good white elephant. You bring it and keep it, and daily you have to polish and keep it. So that might happen, and it is happening. But most of the hospitals deny that. They will tell, I'm doing thousands of laparoscopy, 100. Yesterday also I did like that. So yesterday will be like, yesterday also was the yesterday. So yeah, we all know that. But anyway, let's talk about evidence. If we have to challenge gold standard, we have to tell robotic cholecystectomy, is it safer? Is it faster? Is it cheaper? Obviously, sir already gave this acronym AAA, which is most of the things aligning in this. I did not have the acronym by that time, so let's see if it is safer. Means it's not my grammar of words, it's a PubMed. The other person was asking about the evidence. If you just type laparoscopic versus robotic cholecystectomy, you will get many articles. As the robot was there 20 years down the lane, it was there. So many articles have come, and if you see the older articles, they are a little bit biased because obviously the center who had robo published those articles. But still, when you come to randomized control trials or meta-analysis or systematic reviews where all these bias are taken off, clipped off, and in that, is it safer? It does not claim any superiority. Yes, it has some advantages at somewhere, but that is not statistically significant. So at the max, it will tell it is equivalent in all the things. Like safety means to prevent the complications. So just now we saw the video. In a laparoscopic cholecystectomy, if any newcomer also, if you ask, the only thing he is afraid is bile duct injury. Not because he is cutting bile duct injury, because he might cause a thermal injury. Even if he sees cystic duct, he might injure. That part we are not talking at all in robotic. And all we are using is monopolar, not even bipolar. It is either monopolar or you are going higher to ultrasonic shears. There is no in between. So there we are not talking about lateral thermal injury at all. Probably we need a longer follow-up period and longer trials for coming to that. But as of now, the complication rates are equivalent. Here, if it is a challenge between two surgeries, equivalent is not good. It should be better. So currently, as of now, obviously, there are 5 mm surgery, 5 mm ports. There are people who are doing with 3 mm. There are people who are doing with 2 port, single port, all those. Any port in robotic is, first to start with, it is 12 mm. So if we are talking about port site hernias, obviously we are thinking about 5 mm port closure, 12 mm, it needs closure. Are we talking about pain? Where it is happening, the pain is happening in laparoscopy, it is happening at the muzzle stitch. All which we are doing at port closure is muzzle stitch. If pain should happen more, it should happen more in robotic cholecystectomy because the port site is 12 mm. You have to close it. So it is something like a mini laparotomy, you are closing it, right? So is it faster? Yes, people might claim that I'm the fastest robotic surgeon. Within no time I will dock it. But the same fastest laparoscopic surgeon By the time he docks, he is already finished and having cup of tea. Yes, you can have a cup of tea with a robotic console, but he has finished the case and having tea, but you are having on the console. Yes, so obviously we have docking time which is extra from the operating time. So obviously you cannot compete there at all. So there is no equivalent. It is still, laparoscopy is definitely superior in that point of time now. And suppose means the articulation, all those things are there which we use. If you require 540 degrees or 7 degrees of freedom for clipping a cystic duct, probably you are not clipping the cystic duct at all, because it's right in front of you. There is nothing. If you require 540 degrees of 3D vision and 7 degrees of motion for identifying a the cystic duct, you are not identifying the cystic duct at all. Probably you are, aberrant artery. Yes, you might be. Yeah. Is it cheaper? I need not talk at all. Yes, from Lalith Ashok, this hall to next hall, we can go with Mercedes. We can have Cadillac for a golf cart. We can. But is it required? It's not required. All we require is just you can walk also, you can have a small electric buggy, you can just go there. So obviously, I need not tell about the cost. Cost is extraordinarily, currently not touchable by all. Yes, it is there. Some people are, you all know that hemorrhoidectomy is a very commonly done surgery worldwide, especially in India. And everybody comes with the first question, are you a laser surgeon? They don't really know whether I require laser or no, but they will ask a direct question, are you laser surgeon? So like that, there are many people who comes, I want robotic cholecystectomy. Yes, it is good for them, but as on usual basis, if you talk about cost, obviously it does not have any superiority for now. Apart from that, we also have the tactile sensation, which already Shashi has told. So most of the points have already been discussed in detail, so I'm not going in detail. So from open to lapo itself, we feel tactile sensation is halved almost. So here there is detachment. There is not even, you don't even have a feeling of operating on the patient. Apart from that narrow vision, if you just come out of it, you are in a different place altogether. So there is no sensation at all. There is no connect. There is disconnect. A lot of things about tactile feedback is there, but there is a disconnect. The patient is separate from the operating surgeon. So that also plays a lot of role in the surgery. Training curve, already we have discussed. Sir was just putting it on the simulators. To buy a simulator itself, a economical robotic simulator costs 2 crores. Economical, I'm telling. It's an Indian-made economical, very simpler version, will cost 2 crores. Obviously, Da Vinci has a teaching console which probably is 8 crores. 8 crores. Yeah. Intuitive has a student console. It's quite costly. It's for training, not for robotic surgery. It's for training, simulator. So obviously, it has a steep curve. And it's not a universal skill that everybody learns. One who is interested, one who has resources, and one who can use that resources when he goes out of training can only do the training. At the contrast, laparoscopy, anybody will generally go into training, and if you don't have a laparoscopy in the setup, you hire it. They will give for 5,000, 6,000, they'll come and it can be done. Currently, laparoscopy, robotic cannot be hired. Currently, yeah. Probably later when there are lots of systems and you don't have a usage of that, yeah, hiring might be an option. Yeah, it can come for lease also, we don't know. Yeah. Suppose in an institute with a high volume center, at 12 a.m. or 1 a.m. night, there is a case and you have an option of robotic and laparoscopic. For robotic, you have to have the whole team ready, night duty, whole team. It won't happen. However we talk. Suppose the robotic will come to a stage where robot is there in all the hospitals possible, it can happen. But till then, it is a laparoscopic surgeon who still scores. at any emergencies. So what we are talking here is we have all the tools. A good saying is there, which is one of the favorite of mine: a fool with a tool is still a fool. Whatever tools we get, if we don't know how to use it, where to use it, we still become a fool. So what are the advantages of robotic? If a surgeon is convinced that he can tell the patient this is advantageous for you, yes, that is an indication. If he can scientifically tell, it's not that my gut feeling tells that your robotics cholecystectomy will be better. That is not a thing. If he tells, for your case, you are a difficult gallbladder, for your case I feel robotic cholecystectomy is better, yes, that is an indication. So we have a subset of people who have advantage of robotic over laparoscopy, like a narrow pelvis, repeatedly done surgery, all those things. Yes, that subset we can use, but routinely, as of now, it's not the right tool for all the laparoscopy. So definitely it is used for complex cases, and means for a small theft or a small insect bite, we need not call SWAT team to kill, is it not? So we can just do it, or 100 rupee wala bat bhi aata hai. Good night will do the purpose. Yeah. So currently, as of debate, what I feel, the safe and fast and cheap things, one was equivalent, so let's call it a draw. The others were not equivalent. Laparoscopy was scoring little higher than robotic surgery as of today. I am talking as of today, because there was a disclaimer which I wanted to tell, that I am also trained in robotics. I am not against robotics. For the topic, for cholecystectomy, is robotic needed as of now? It's not. And currently we heard Shashi telling that initially all of the surgeons will go for cholecystectomy for practice. For practice. It's not an indication. It's not a patient indication. It's a surgeon indication. Yeah. Somewhere we are playing around in ethics. We can play around a little bit. We cannot too much also. So we cannot tell that to the patient. So currently for upper quadrant surgery, still I feel till now laparoscopy scores over the robot. Thank you.
Thank you. Can I just ask you? It was a good debate. How many of you agree that all points were laid bare from Dr. Sunil as well for laparoscopic cholecystectomy, and from Dr. Rajesh for robotic cholecystectomy? All points were laid bare. How many of you agree? So this is a place where probably I'm going to ask you another vote, and you have to rethink now, based on the debate and based on your personal conviction, how many, and please only surgeons raise their hands, how many of you would still continue doing or offer laparoscopic cholecystectomy to a family member of yours? And how many of you would go with robotic cholecystectomy for a family member of yours? Okay, so there's a couple of robotic surgeons raising their hands. Let me rephrase this question, and again, only for surgeons. How many of you want to train in robotic surgery and want to do robotic cholecystectomy? Thank you. Thank you so much for this honest answer. And thank you, Dr. Sunil, Dr. Venkatesh, and Dr. Rajesh.
Thank you to both the speakers. We quickly move on to another important area, which is abdominal wall reconstruction. So it's my pleasure to invite Dr. Saurav Mishra to deliver his lecture on robotic abdominal wall reconstruction and hernia surgeries. So may I request the respected chairpersons to kindly take the seats. Dr. Sheila Chakravarti, Dr. Richa Mishra, Consultant MAS and Robotic Surgery, Fortis BG Road. Dr. Sanjeev Shetty, Consultant MAS and Bariatric Surgery, Fortis BG Road.
Hi, good evening, ladies and gentlemen. As surgeons, we have always tried to enhance our skills to get a better patient outcome. We have all struggled with the angles provided by the laparoscopic surgery. And we have, at the end of the day, we have really fatigued ourselves. What if we had a platform where we could give a better patient outcome and enhance our longevity as a surgeon? Yes, I'm talking about the robotic platform. So all the discussions that we have had right now, it was about the patient safety, the things, but no one really talks about the surgeons himself. As you get trained, let me tell you something about myself. I have the first laparoscopic hernia surgery I performed in 1999 at Gangaram Hospital in Delhi. Since then, I have done almost about 3,000 laparoscopic hernia surgeries. At this point of time, if you ask me, I will never perform a laparoscopic repair until unless the patient wants. And I have my reasons. So if you look at the hernia spectrum, you have a variety of surgeries that you can perform, right from inguinal hernias to IPOMs and ETEP with the abdominal wall repairs and the TARs and the ETARs. Now the the robotic inguinal hernia repair being the simplest, and the robotic ETEP TAR being the most complicated surgery possible. But if you really want to do a robotic ETEP TAR, you need to go through the process. You need to get yourself started with the inguinal hernias and gradually go up. Why I say it's a simple surgery? Because it's exactly like how you would do a inguinal hernia laparoscopically. The ports are just the same. A brief about how the video about the surgery. So it's exactly like this. What we do is we initially put all our sutures as well as our meshes inside beforehand so that we are not disturbed in between. The surgical procedure is just the same. We mark our flap and start operating towards the symphysis pubis. That is supposed to be the first line of our vision. That will tell us the depth of the surgery. Now, having finished this part of it, we have to develop the flaps around that. Now, if you look at it, this kind of vision will never be possible in a laparoscopic surgery. Can you imagine me holding this flap without bursting it? Now here, I want you to just wait a minute. Oh, I'm sorry. I don't know how to increase the speed. So if you look at the fascias of the lower abdomen are very, very thin, and if you're trying to do that, you really need to you have a lot of dexterity not to make multiple holes there. Now, what I want you would like to appreciate here is that the whole of the field is absolutely bloodless. It's not because we have a huge amount of differences in our equipment. It's because of the dexterity of the equipment plus the vision that we are getting. Now here there are two layers that you can see. You can go anywhere you want. In laparoscopically, you will never find this. Now this is exactly where we left. So now you will see that I am trying to go underneath this. Why? Because the fat belongs to the periphery. This is exactly the Bogros fascia that you want to get down. This is where just behind this are all your nerves. The iliolinguinal nerve, the generative branch of the genitofemoral nerve, the femoral branch of the genitofemoral nerve, all being behind this. So you can see absolutely no bleeding. Why? I have a good vision, I have a good traction, and I'm able to find the planes which I would have never ever thought about in laparoscopic surgery. With this kind of vision, I am very sure I am going where I want to. You can just see I'm not doing anything. I'm just using monopolar and going around. So these are the cord structures which would otherwise be seen. We are now trying to get being very, very close to the peritoneum. Now, in a while, you will see the cord structures, and so this is the hernia which is coming into picture. This is a direct hernia, and there is an indirect hernia as well. In a while, you will also see the pubic symphysis and the Cooper's ligament. Now you can see the hernia itself. I'm trying to reduce that. I dare not use a cautery here if it was not a robotic repair. So this is again one of the things that you could do. You can turn the robo upside down. The camera will show you exactly where you're going with a very different view from a laparoscopic surgery. So you need to keep on going in the midline. You need to develop this space of Retzius. Can I have a pointer, please? No, if I touch it, it just goes to the next slide. Okay, so now you can see the cord structures coming into view. Any bleeding? Absolutely nil. And I'm just using the this is what you can see this little by little, but every time I'm using a cautery here. I'm using these very, very close to our femoral vessels. Absolutely no problems. So this was a bilateral hernia, so we did it on the other side as well. So this is the other side, but we are more confident because we know our landmarks now. So we go to the next part of it. So as we look at it, we have graduated from the inguinal hernia. Now we go on to the more complex hernias, which is robotic TAR repair. Now basically this robotic TAR repair is basically it's a retrorectus repair where you're going underneath the rectus, and this is the transverse abdominis, and we lift the transverse abdominal up so that you have a space between the transverse abdominis and the peritoneum, and that's a delicate job. Anyone who has done a laparoscopic repair and done a TAR repair like this, I would really congratulate, because it really requires a lot of skills to do that. Most of the time you will have multiple holes. So what you do in these patients, these huge hernias, this patient had a hemicolectomy, open hemicolectomy, multiple leaks, and then there was a colostomy, the colostomy closed, and then the hernia reoccurred, and someone went in and did the hernia surgery, and then it failed. So this is the fourth surgery. This, and again, another one which has a fenestrial incision, and this patient had twice been operated before. This I'm definitely sure most of these surgeons who would be here would operate it with an open surgery. But as you become better and better in robotic surgery, you would like more and more to do these procedures, because that's where the value of your robo comes in. And I would agree with Dr. Sunil that these are the patients which actually require robotic platform. But how do you reach there? How do you decide that? So you have to go through the process. So once you have decided that you have to do a transverse abdominal release repair, either you have to decide beforehand, you have to do either a bilateral repair or a unilateral repair, or you want to do an intra-abdominal approach, or you want to do a E-TEP approach. That is, without opening the abdomen, you have to go between the planes and create a plane there to put a 30 centimeter into 30 centimeter mesh. And these patients, believe me, will go home in 2 days' time. That is where your value of robotic surgery comes in. So you need 3 instruments. You need a fenestrated bipolar, a 30-degree camera, a scissor, and a needle driver. That's what you need. This patient is usually, you will require this patient, a lot of times what happens is that you will require these ports to be placed on the sides. And when the ports are placed inside, you have a small abdomen, and there is very little space between the rib cage and the pubic bone. And that's where you want to have more space, so you break the table so that, and you want the umbilicus to be exactly where you want to break so increasing your real estate for your ports. Now, for a TAR surgery, the robotic arms have to be on the head end, because you will require the boom to move the right and the left without actually undocking. I mean, you have to undock, but without moving the robotic arm. This is usually the ports that we have, which is exactly like how you would have in a laparoscopic surgery. This is the huge midline scar and a midline. So this is what we would to have 3 ports on the side, on the right side, and 3 ports on the left side. And one of the port will be a visiport through which you will enter and then create another 3 ports on the other sides. But if you want to do a E-TEP, that means without entering the abdomen, that's where the whole your expertise comes in. And this is where it would be. So you have 1 port at the head end, which is just below the 9th rib and towards the midline, about 2 centimeters from the midline. And this one is the visiport, and then you enter this and make 3 other ports here. Now, that is precisely for a unilateral TAR. If you want to have a bilateral TAR, you will have to do 3 more ports on the other side. So we come to this. So there are steps to do. So this is first is to do create a space so that you can at least put your ports. This is a potential space, so it's not really a space. So now you have 3 ports that you have made. The robo is docked, and you start your dissection by incising the posterior sheath. On the top of it, for convenience sake, this is the rectus abdominis muscle. This is the posterior sheath, and you're trying to make a space between the posterior sheath and you are trying to do a crossover. Now, the advantage of robo here is multifold. So you keep on operating. In a laparoscopic surgery that I started doing many years ago, and I have now switched over to completely to the robotic platform, if you have a pneumoperitoneum here, because there's a very thin part of it, your space is gone, you will not be able to proceed any longer. You will have frustration and frustration, but in robotic platform, you continue doing it. So now you can see that you have crossed over, you've gone to the other side, and you're creating the space here. This is extremely important. The being that as you go and you miss the other side, you might end up injuring the elbow, most likely you will have a very bad diversion where you have to open the AWR point, I have a new, I opened these, but I continue to do it without these, with these, without any problems. Create the space. Another important factor, if the space is bloodless, you will be able to go where you want. The movement, that's you will make a little more easy for you to understand. This is the left right rectus, and this is the left rectus, and this is the defect, and we are trying to now unite the two rectus muscle in the midline in the lower part of the abdomen. All continuously we use the cautery. The planes are extremely important, and you can see that now we have created that space. These are the neurovascular bundles that we have preserved on the side. Now in the lower midline, what's happening now? This is extremely important part of the procedure where we have decided that what we want to do. We want to do a bottom-up TAR, or you want to do a top-down TAR. Here we started thinking that probably let's do a bottom. Then because it was a little stuck there, we decided that this was the best thing to do, was to do a top-down TAR. Now you can see the peritoneum, which is extremely thin here. What we are trying to do is to cut the insertion of the transverse abdominal muscles and slowly push it out of the field so that we get more and more of peritoneum to close the posterior fascia. Now here again, there are going to be two planes that you are going to see. I'm sure the hernia surgeons would be able to appreciate this. There is a pre-peritoneal layer, and then there is a pre-transverse salus fascia. With robot, you can actually see these two fascias beautifully. I have never seen, I did a lot of these laparoscopically. I never saw these two fascias differently. So as we go down, you can see that the transversus abdominis is being incised from the upper part and slowly pushed onto the. So as you do, the force on the midline becomes less and less. So you can actually, there is no right or wrong. Now you can see actually the two planes. One is the pre-peritoneum and then the pre-transverse salus fascia. Now you can appreciate it. So here we are trying to, the two sides from the top down and where we had operated before, we are trying to unite that, and we make it into one large plane that would be. We had been doing these surgeries before laparoscopically, but believe me, at the end of each surgery, I would always wonder how long I would last, because these would last for about 3 to 4 hours, and standing there and operating and getting frustrated because there would be a lot of holes. Here, absolutely no holes. In between, you may find a little bit, but more or less. So now we come to this, the other part. The next part is to repair the midline. There are multiple holes down there, and then there is, as you go up, you have multiple more defects. So the anterior and the posterior defects have to be sutured and got together. Now this is important, not because you can do this, that you can just close these holes, but does not get you to why we doing these repairs. We want a functional abdomen. So when you do a functional, when you try to get a functional abdomen, you suture from the lower abdomen to the upper abdomen and get the two muscles in the midline. This is the principle of AWR. Anterior wall repair does what other surgeries can't do. You can't have an IPOM. You can fix a muscle, you can just fix a mesh there and come out. But you will never be able to get a functional abdomen which you will get in an AWR. So you can see this is where we slowly, the other thing what is important is that you have to make sure that you use the right sutures. Now this suture is a V-lock suture, which is 1/0, and a 1/0 suture, and that's just about 15 centimeters. The length of the suture is important because if you take a larger suture, you will spend more and more time because the space is so small, and you will keep on struggling with that. The second most important thing is that you have to use multiple suture and use suture from the below to up. Drop down the intra-abdominal pressures from normal 14 to 8. When you do that, the compliance of the abdomen becomes more. So, having sutured the anterior fascia, you want to now suture the posterior fascia, and this is what the hole in the in the posterior fascia is. This is easier to repair because you know that suturing on the ground is easier than doing it on the roof. This has to be absorbable V-lock suture, usually about 15 to 30 centimeters should be fine. And the most important thing is we don't try to approximate the posterior sheath. We just try to approximate the peritoneum. We want just a small barrier. We don't want a tight closure below. If we do a tight closure, this is going to just open up in the postoperative period as soon as the patient coughs. So you can see that the space created is almost about 30 by 30 centimeters in the abdomen. So a lot of times what we have done is we have done these mesh placement robotically. But I find that laparoscopic placement of the meshes is much more easier and faster because we have already operated almost about 4 hours here, and the other surgeons would be waiting for it. And simply I find it more convenient to put a 30 by 30 mesh laparoscopically in a place where you have already created a huge space. So this is about a 30 centimeters into 30 centimeters mesh that we have placed. We put in a small drain there for a day, overnight usually. In the morning, we take out the drain, and these patients are usually discharged in the next post-operative day. So just a brief, excuse me. So in the conclusion, I would say that every surgeon needs to train in robotic platform now. I'll tell you the main reasons. There is a study in US which has been going on for the largest, about 10 years now. And there's a critical mass of a procedure which is at 19%. 16 to 90%. If the procedure goes beyond 16 to 90%, it grows exponentially. So in US, at this point of time, the robotic surgery is about 25% in all general surgeries and GI surgeries. So 25% you're going to see the next decade is going to be about 40 to 50% of these surgeries, all general GI surgeries are going to be robotically done. That's not what I'm saying, it's the data. Anyone who wants to start a hernia surgery has to start with inguinal hernias. You train inguinal hernias, you do your job well, you understand the plane, you understand the traction involved, you get used to it, go to the next. So it requires a very robust understanding of the human anterior wall anatomy. If you want to do a TAR, which really justifies using a robot, which will really give you the satisfaction of being a robotic surgeon and a hernia surgeon, then you start with a mentor, get someone to get along with you, and then you are on your way. Thank you.
Thank you, sir. Excellent talk and excellent video. Any questions from the audience? Yes, sir.
That is a wonderful talk. My question may look a little funny and silly to you.
Absolutely.
Imagine there is a senior surgeon who has done hernia surgery, thousands and thousands, senior surgeon. On the other side, there is an young robotic surgeon who has done 20, 30 or 50. Let me tell you, I'm not a surgeon. I'm in a dilemma whether to send my patient to the person who has done about 20, 30 robotic surgery, or to a general surgeon who has done laparoscopic surgery in thousands. Naturally, I will be inclined to send my patient towards the person who does lap surgery, senior surgeon. Am I wrong? What is your comment?
You're absolutely right in being skeptical about your surgeon of choice. I would like to put a question to you. If you had to go to the airport, you had a choice between a BMW and a Maruti, costing the same. It's not costing to you, which is safer and which has more comfort. What would you choose? Yeah, so here is your, I'll come back, jokes apart. See, sir, I understand that the older surgeon would like to continue doing what they want. And as a clinician, the whole process here, why we are together here, is to put forward in front of you our plea that this is what is the future. And this is what is going to be the next. As a referring physician, you would like your patient not to have bleeding. You would like to have lesser hospital stay. You would like to have a more robust repair where the patient will not come back for a resurgery. And you want your patient to be going faster to work. Then what happens is the cost of the surgery is very meager. The increase in the cost of surgery is very meager in front of all this. My take on this. Yes, sir.
Hi, Saurabh. Good presentation. A little different opinion of mine on this. It's like you go for an Apple phone, you go for 16, 17, you keep buying. If you use it, well and good. So for people who are going to or aim to do complex surgeries, I think you must learn robotic, and in which case you have to start simple and go bigger. So therefore, if you have this armamentarium of all surgeries, I would choose depending on a patient rather than on just because I do robotic, I want a surgery to be performed on someone. So I think informing Dr. Shrikant, yes, that I think this is a good tool, but not meant for all. They can choose.
Thank you, sir, for that wonderful video. We do quite a bit of laparoscopic abdominal wall reconstructions. I mean, whatever you have shown, we can easily do it in laparoscopically. My only thing is, can you do robotically the first retrorectus spleen creation one? The other thing is, you said you never want to do the laparoscopic surgery anymore. Is there a reason?
Yeah, so patients come to us because they have faith. And as a surgeon, I need to give them the best alternative I can. In my hands at this point of time, I can bet that I wouldn't be able to do, despite of doing about 3,000 laparoscopic surgeries, my robotic results would be about 10 times better. Just because I can see better, I can fix my mesh better, the pain is less, the patients are not complaining. The other day, just about 2 days ago, we had operated one patient when I was in Apollo Hospital on the right side. This patient had, I had done a laparoscopic repair and I had done a TEP repair on this patient. And the patient had came now and said that I have a hernia on the other side. What would you like to say? I said, I want to do a robotic repair this time. He agreed. I did it. And frankly, I wanted to tell him that you are the right person because you had a laparoscopic surgery on one side and robotic surgery on one side. What would you do if you have another surgery planned for your near? He said, I will never get a laparoscopic surgery done. Robotic surgery, my pain, my recovery is 10 times better. And he was the right person because I had never done surgery on myself. These are the people I need to believe in. And I was really overwhelmed with the feeling that, yes, we are going the right way, and this is the way to go.
Yeah,
and laparoscopic, and I understand, sir, and you are a very gifted surgeon because you are able to do all these surgeries, but I can bet it, you must be in 1% of the surgeons around the world who are able to do complex AWR repairs laparoscopically.
The only advantage I see in robotic is the suturing, especially on the top. That may be a little hindrance for the laparoscopy. Otherwise, yeah, both seems to be okay. Yeah, thanks.
Sir, if I can interject, to add to Sir's point, I think there are advantages, especially in people who are overweight or obese, in the robotic console, and also especially with the history of prior surgery, where adhesions are there. Laparoscopy will be very tiring, it will be very long. Robot will give the comfort of, to the surgeon especially, and also visualization and everything else like Sir mentioned.
Sir, I really appreciate your question, sir. You put a very valid question. Experienced surgeon versus a new surgeon doing a few numbers of robotic surgeries. Your question is a very valid question, actually. So here we are not comparing the robotic technology with the laparoscopic technology. We are comparing the experience of the surgeon with technology. These are not equal platform of comparison, actually. So it's a very tough question to answer, actually, but I can vouch that our surgical gastroenterologists here, minimal access surgeons at Fortis, are experienced as well as they do robotic surgeries. So you can refer the case to Fortis. I myself am a cancer surgeon at Fortis, Dr. Sarath Chandra. Thank you.
Thank you, sir. Thank you so much.
After doing a lap TAR, I'm sure we can't post another case for the day.
That's
and
true.
A robotic TAR, I think easily we are able to manage another 3 or 4 cases in the day. So it does improves a productivity of a surgeon, as rightly mentioned by Dr. Mishra. So I think that does make a lot of difference to the surgeon and other patients who are in the row to be operated post these complex repairs. So robotic does give an added platform there. Thank you.
Well, the one thing we have to remember is that we are all human beings. As surgeons, the longevity of surgeons is about 13 years less. So let's increase it by a few years with a robotic platform.
Any other questions there?
Only a comment. You see, usually as a general physician, I referred my patients many times to surgeons and all those things. I usually leave the choice to the patients to select a surgery, robotic or laparoscopic, depending on their purse.
Thank you, sir. So Dr. Appaji, thank you. I've just put a small thing in there is that these days about 75% of these surgeries that we are doing are insurance approved. So most of the insurance companies are approving this. I mean, it's not we are not trying to rip off the insurance companies, just that, you know, it's a better platform and we are able to give a better choice. That's the reason why insurance companies are also paying the hospital for these higher end surgeries, even if it is, it seems to be a normal hernia surgery.
No, actually, I wanted to come to the subject of insurance.
A few, well, 75%.
I wanted to come to the question of insurance.
Yes, sir.
Medical insurance. Medical insurance, people won't pay money for robotic surgery. If you mention in discharge card, it has been done as a laparoscopy, they will pay the full amount. But if you mention it as robotic surgery, you won't get the money. That's the question. Because my own wife had a surgery recently in Fortis. The bill was 5 lakhs. Insurance paid only 1 lakh in advance itself. But later on, they never paid a paisa also. And the money had to pay not by check, by my cash only to Fortis Hospital. That is the difficulty. Now, what I want to say is again, I have experience with other surgeons, with other hospitals. The other hospitals, when they do robotic surgery, they won't mention it as robotic surgery in discharge card. They mention it as laparoscopic, and they get the full money. That's the advice I am trying to give to all the surgeons, robotic surgeons.
Sir, I'm sorry, I disagree with that, because that amounts to fraud. And I am very clear about this, that yes, I do get patients who would say that please don't put it as minimal, or you put it as laparoscopy and do I simply refuse, because it's not because of that I want to really do the robotic surgery. It's being it's upholding your ethics. So at the bottom of it, we are all surgeons who don't like to do procedures which are going to harm you, because one of these days it is going to have a problem, because one of these patients are going to go back and say that it is written laparoscopy and you have done robotic. So the patients are very smart now. So,
look at the financial aspect. That's exactly.
Yes, financial aspect. Coming to the insurance aspect, I think a lot of people are doing good work. Especially the robotic companies are working very hard in Delhi as well as around the world, because insurance reimbursement is a problem around the world. So what's happening is that what we need at this point is data. We want more and more data to be given to them so that they can come to a conclusion like what was happening when we were transiting from the open stage to the laparoscopic stage. At that point of time, there was a lot of resistance with the insurance companies just not wanting to pay for laparoscopic surgery. Now the data is so robust, they can't refuse it. So coming to the next point is that IRD has now mandated that none of the insurance companies have to refuse robotic surgeries. If that does happen, your patients have got a right to go to the ombudsman, where it's like a judge who can see and decide if the patient agreed, doctor agreed, patient had the advantage, the insurance company has no right to refuse them. So then these people get the full reimbursement. This is the game which insurance companies like to play, that if you want to take a robo, we'll give you half, which is not logical. You are using our advanced platform and you're getting half the money. It's not logical.
The insurance, the form they give, it will be mentioned in a small letter, robotics are not allowed.
Exactly. So this is where the IRD has come in and said that you cannot refuse robotic surgery. So that's the bottom line, sir. So
could it be mentioned as a robotic assisted laparoscopic surgery? Would that will be?
Well, you can do that, but what will happen the moment the robotic comes in, the word robotic comes in, they will not approve. And they will try to dissuade you, they'll try to trouble you, and then finally a lot of people just pay up and go home because they don't want to be hassled by it. But the right way to do is to go ahead and file a complaint in the ombudsman. Most of the time the patients get the money. That's my experience all the time.
I think in the interest of time, and because there are multiple sessions also pending, these are all dinner side discussions. We can continue with that.
Yes.
Thank you, Dr. Saurabh Mishra.
Thank you, sir.
Dr. Richa and Dr. Sanjeev.
Thank you, Dr. Saurabh Mishra, sir, for sharing your valuable expertise. We now move into one of the most rapidly evolving fields of gastrointestinal surgery. It's my pleasure to invite Dr. Manish Joshi to speak on bariatric surgery, newer strategies for obesity. May I request our respected chairpersons to kindly come onto the stage. Dr. Shalini Joshi, Additional Director and American Board Certified Physician. Dr. Prem, Professor Surgery of BMC. Dr. Sunil Kumar, sir. Dr. Wasim, Consultant. Dr. Sanjeev Shetty, Consultant.
So how many of you have dealt with obesity in a close family or friend circle? A patient with obesity in your own close circles? Most of you would have. How many of you find management of obesity a bit challenging? And how many of you would like a simplified portfolio so that you can have some understanding to carry on forward for your own patients as well as for your prospective patients? We are just trying to see in the next 20 minutes. We are cutting down on the time so that everybody can go have a hot dinner as well, because Lalith Ashok doesn't wait for us. They will serve the dinner at 8 o'clock. So to have a hot dinner, we'll try and speed up the entire process. Is that okay? Yeah. I would like to invite Dr. Shalini Joshi, Additional Director of and Board Certified Physician, who deals with a lot of obese patients and pharmacology. Please, if you can start off the proceedings. And can you have the slides on? Slides on for Dr. Shalini Joshi. It's there in the file. Yep. So meanwhile, if you can just check. So meanwhile, obesity. A simplified definition is having 3 or 4 things. Obesity is chronic, which we all know because it lasts more than a year. It is relapsing. If you don't continue the diet and exercise, it is always going to bounce back. That is the yo-yo phenomenon. It is multifactorial. Multifactorial, that means there is no one reason or one option or one cause that can be easily managed. And most important, it is progressive. So what do you mean by progressive? If the weight is not managed, there is going to be mechanical problems and metabolic problems. Mechanical problems like joint pains, back pains, and metabolic problems, all of us know: diabetes, blood pressure, GERD, gout, DVT, obstructive sleep apnea. A lot of issues come up. So this is a basic understanding that it is chronic, it is relapsing, it is multifactorial, and it is progressive. So the answer or treatment is not one size fits all, or I'm a bariatric surgeon, I'll offer only bariatric surgery. The idea is to look at the spectrum of options available and choose and tailor fit the right option, or in understanding with the counseling the patient, what is their level of understanding, what is their expectations, try and match their expectations rather than offer every patient bariatric surgery. Are you on? So this is going to be very interesting. I want you to follow Dr. Shalini Joshi.
Thank you so much. I think we've been sitting for last 2 hours. So very respectfully, I will ask everybody to rise from your chairs. That's a very good. You are doing excellent for your body. I think give round of applause to yourself. You've been patiently sitting, but I know as surgeons you stand. I think I'm in very much minority, so I should not do more stunts. But have a seat, please. It gives a very good circulation. This getting up is a good idea. I tell to all my IT people, I just want to do it because I do it in my diabetic conferences which I organize. So basically weight, everybody talks about it, and it's not that in 2026 it's a new thing, or as in social media it's exploding. I'm sure everybody has heard Vigovi, Manjaro, and it has been painted in many different ways, but it is not new. So it, as far as in early 20s, can anybody tell me what is this ad about? Hint is it's something to do with weight loss. So it is basically sanitized tapeworms in early 1900s, when ladies wanted to get thin. They would actually consume the tapeworm, and it's a real picture. So in 1912, La Persete, a French company promoting sanitized tapeworms for weight loss, they were sold with the line, eat, 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 always stay thin. So, well, we have much better things now, and definitely we're going to discuss it. Arsenic pills, fat dissolving soap, and I mean, can you imagine what would happen? The fat will, you know what would happen. I mean, arsenic is carcinogenic neurotoxin. Then came the grapefruit diet. That was very popular. So what all things are done in the name of weight loss in 50s? So the thing was, you can eat everything as long as it is followed by a grapefruit, you will lose weight, which is not true. We all know that. So it became a Hollywood diet. They were told that you can have unlimited bacon and eggs, but as long as you ended with a grapefruit, you will lose weight. Then comes the most dangerous weight loss trend, with the social media. 2010, I came across this. So, they would put the cotton ball and it will be full of juice. They would eat it and it will give a fullness. It actually caused, surgeons will get cases for that. It will cause intestinal blockage. And the cotton balls were not made of cotton. They were usually polyester. One of the most dangerous diet fads ever observed. And it is sad that now the thing is, thank God we are in 2026. In fact, from 2017 in US, GLP-1s have been used, FDA approved, for diabetes and weight loss. So we're going to be talking more about various lifestyle modification, pharmacotherapy, and surgical therapy for the obesity. Over to you, Dr. Manish.
Thank you. Can we have a round of applause for bringing the historical aspect nicely covered by Dr. Shalini? Which one do you think you would try if you were in that era? Tapeworm? So I'm hoping this will come up. Yeah, thank you. So post-pandemic, all of us have noticed the increasing trend that the world is getting fatter. And this is a 160 kg patient being prepared. But yeah, the idea is not to talk about this particular case, but to give you a spectrum of options. And we have esteemed panelists here. Dr. Shalini, Dr. Sunil, Dr. Prem, Dr. Wasim, Dr. Sanjeev. All of us are going to discuss about various options for various category of patients. And like I said, there is no one size fit all. We need to look at the patient's understanding, requirement, and match their expectations with our expertise. It cannot be only bariatric surgery. If I take a rough understanding of clinical practice, if you see 100 patients in your clinic, how many of them actually convert to bariatric surgery? If you see 100 patients with obesity, how many of them come to you as a bariatric patient, as a prospective patient?
So I think even that trend is changing. Maybe if you go few years back, if 100 patients, maybe 30 were at least getting converted for surgery, 30% let's assume. But now with the GLP and all, what has happened, it has come down. Maybe 10 to 15% are getting converted.
Do you agree, Dr. Wasim, in your practice?
Yeah, 10 to 15%.
10 to 15%. Sanjeev, same, similar? Anything you want to add?
Yes, as sir said, there is a decline, but I think our Western colleagues are also seeing an uptick in the this thing after patients who have been non-compliant with or failed on GLP-1 analogs.
Okay.
They are coming back for.
Can we pass on the mic to Dr. Shalini? With the introduction of the new molecules that are available, how much of your practice of obesity has increased or decreased, or what is the trend for you as a physician, as a bariatric board-certified obesity physician?
So basically, we had, few decades, all anti-obesity medications were coming in and were taken off the market. So before this GLP-1, we actually did not have anything to offer besides orlistat, which, as we all know, did not give much result to the patient, very much. So basically with GLP-1 is the first anti-obesity medication which has shown absolutely fantastic results overall. Like now diabetes, we don't say glucocentric, it is cardio-renal. Same way GLP-1.
So has your practice and queries increased? Has a lot of patients started flowing in asking for GLP-1 and Mounjaro?
Absolutely. Actually, it became the phase 3 drug when it was taken by Elon Musk and all the celebrities. So already the noise is so much. So people come actually and they say, I want Mounjaro.
Okay, let's take a poll. How many of you have used it, either tirzepatide or semaglutide? So there are a couple of hands and some of the doctors have already used it. You used it for yourself or patients? Fair enough.
I have 2 colleagues in mine in Fortis, doctors who have used it and they had fantastic results.
So doctors have started using it, which means that there is something to it. So let's look at what all options are available. Yes, we talked about the newer molecules. We'll talk about a bit more. You can keep holding the mic. Next question is again back to you. We also will be looking at other solutions. One is endoscopic sleeve gastroplasty. We have a couple of gastroenterologists in the room, but probably we'll talk about it. Intragastric balloon and sleeve gastrectomy or any bariatric procedure. So let's look at Dr. Shalini. Can you quickly give us a overview of the newer pharmacological therapies? Does it work? And in your practice, how does it help you or help the patient, and the intolerance part as well?
For 1 second, I thought you were going to ask me sleeve gastrectomy. Oh my God, thank God.
There are too many surgeons in the audience. So
yeah, I'm in minority. So basically, GLP-1, semaglutide, has been in the market from 2017, and we were using the similar cousins, liraglutide. So it's not a new molecule, number one. Everybody thinks it's some experimental thing. Patients, not doctors. Maybe some surgeons also. So basically, it has changed the menu because it is available in an injection form. Every week, the patient is told to take it.
So let me ask you a rapid fire question. Is that okay?
Yes.
Right now, tirzepatide is better or semaglutide?
Both have their places.
Both have their places.
Depends
Which are you prescribing more?
In diabetic, we'll go with semaglutide, and it gives 10 to 15% weight loss. If you want more, we have dual agent, GIP, GLP-1, which is tirzepatide. It gives almost 15 to 20% weight loss.
Right, and you counsel the patient that it's going to be a dose which is going to be loading and increasing over a period of a few months.
We have to go titrate it, and some GI side effects we have to manage. It needs a lot of counseling, at least 30 to 40 minutes. I go through the checklist, inclusion criteria, exclusion criteria, and counsel the patient.
Fantastic. Do you say that these medications or injections are required lifelong?
That is a question they ask. So the way we have started counseling patient is that yes, you have to take it for a year. And we believe that after in 1 year we would have changed his behavior, the lifestyle, the way he talk, the way they eat the food. And then in my experience, my first patient has started last June, and you have to know what is their target and your target. Sometimes their target and your target doesn't match, so we have to counsel the patient, and then we can sometimes
Fair enough.
de-escalate and keep them on a dose.
So we are trying to lay bare all the points. It has to be taken possibly a longer term or lifelong treatment.
Yes, it is same as diabetes
to maintain
and
the
high
weight
blood
loss. And there is GI intolerance. There could be nausea, vomiting, diarrhea in most patients. So it can be something that you need to advise. surgeons, Dr. Sunil and Dr. Prem, from the government sector. They have done a wonderful job in establishing a bariatric unit in Victoria Hospital, Bangalore Medical College. Please give them a big round of applause. It's easier in private hospitals, corporate hospitals, but doing it in a government sector takes a lot of gusto and determination. How difficult was it to set up this thing, and what are the numbers that you do in the government setup?
Initially, we had a lot of difficulty, sir. As we know, doctors themselves are a little resistant to accept that obesity is a disease initially. And we had to do a series of CMEs for the doctors of the other departments to tell that obesity can be treated. It need not be taken as the lifestyle or the obesity as a sign of prosperity.
Fine.
So
that is what Indians say. It's a sign of prosperity.
So initially it was slow. Now every week I do one, Prem does one. So
Fantastic.
that is because we cannot cancel other cases. Yeah. We don't have a dedicated bariatric OT, so we have to.
Fantastic. Thank you for that response. I'm going to quickly show a video of the next option that is available for weight loss. This is a endoscopic procedure, endoscopic equivalent or thought of equivalent of endoscopic sleeve gastrectomy. It's an endoscopic sleeve gastroplasty. So this is the endoscopic image of the stomach, the incisura, and this is a special overstitch device which is one company has manufactured, and this is the linea incisura where two lines are marked in the greater curve, and this is the device which is used for suturing and bringing the greater curve and plicating it from inside. And this gastroplasty was claimed to be equal to sleeve gastrectomy, and the results were quite good. It was quite popular among medical gastroenterologists who were doing endoscopy and wanted to get into obesity management. And this is the end product. This is after the gastroplasty is done. So this is an animated video. We were in the COVID period. There was still a lot of enthusiasm for this particular procedure. I remember setting up an international team which had come and done this procedure, and a lot of us from Bangalore got trained, but probably none of us are doing it at the moment. And why? I'll just try and show this video. For every suture, there's a series of 10 or 12 steps that needs to be made. This is to put one suture, you need to do that entire thing. Plus the endoscope costs, it doesn't go into the same endoscope. It is a double channel endoscope required. The stitching device itself costs 2 to 3 lakhs. Each suture costs around 20,000. So until things evolve, this seemed to be more costlier to the patient than a simple bariatric surgery. So it probably is gone out of favor, and there are still some modifications in endoscopic industry trying to figure out what next to be done and how to improve this. Maybe it will come back in a different avatar. So Dr. Prem, for you, this is an intragastric balloon, Allurion, and probably has been popular saying that it is no endoscopy, no surgery, no anesthesia. What has been your experience?
So I just mentioned the numbers of bariatric surgery coming down just because GLP. I think I forgot to mention this balloon also. I think even this has sort of occupied a space somewhere between the medication and the bariatric surgery. Maybe even now sometimes I do 4 to 5 balloons per month. These patients are actually eligible for bariatric surgery. They fit in right into bariatric surgery with all the criteria and the recommendations. But this is an easy way option. Maybe they are hesitant for the drug because I make very statement for most of the patients that for the drug we don't have long-term results data. Since the drug itself for new, you cannot say what will happen after 20 years.
Dr. Shalini is looking angrily at you, but okay, we'll continue.
2005.
So Indian data, Indian data, sorry if I missed out the word. So yeah, the balloon is doing good, but The weight loss is very limited.
So weight loss is very limited. And
yes.
how long does the balloon stay in the stomach?
The balloon stays for 4 months in the stomach.
So it is a temporary weight loss option. So remember these things, very important in decision making. It's a simple swallowable pill, Allurion balloon goes inside just like a Ryle's tube. It can be done in the OPD. It takes 15-20 minutes, Prem, to put in the procedure.
10-15 minutes.
And you inflate it with 550
Yeah, 550
ml of special formulated fluid that comes along with it. Okay, so Dr. Prem rightly said it is a temporary weight loss option. And this is the data about the balloon. There is 10 to 15% of total body weight loss on average in 95% of the cases. And so this is how it looks when it is inflated in the stomach. Cost, again, a prohibitive cost. It is still the same as any surgery, and that is where it probably, again, fails to impress a larger population requiring treatment. And this was one of the comparisons of ESG and intragastric balloon. And of course, at 6 months and 12 months or 18 months, the ESG or endoscopic sleeve gastroplasty was found to be superior. But for this patient, Dr. Shalini, will you advise pharmacotherapy?
I don't know this patient meaning. How much is the BMI?
BMI is 60 plus. So
see, I would not say this is medicine versus lifestyle versus surgery. I think we have to choose the right therapy for the right patient, and definitely surgical options have absolutely great all these I'm forgetting the name of that trial, which clearly shows that surgical options.
This patient, would you use it as a first-line
Surgery.
treatment? Surgery. Thank you. We'll go to the surgeon then. Dr. Wasim, how many numbers of bariatric surgery you've been doing in Bangalore monthly or roughly? I see a lot of cases being posted, so I need the
overall post-COVID, we would have done more than 75 to
75 bariatric surgeries. And in this patient, how do you counsel the patient whether you want to do mini gastric bypass or whether you want a sleeve gastrectomy? How do you choose?
See, I think every such thing has a role in treating patient. So first thing I always start is diet and exercise, because nothing is permanent other than death. So even if you diet and exercise, you do surgery, you lose weight, there's a chance of gaining weight again. So it's just a matter of number of years. So let's say, to put a ballpoint figure to it, if you stop medications, you'll put back weight in 2 to 4 years. If you do sleeve gastrectomy, the chance of gaining back weight is between 8 to 15 years. We see a lot of patients whom we operated almost 10, 15 years back, they're coming back with weight
In
gain.
the patients who have regain of weight post-bariatric surgery, post 5 years or 8 years, do you think the pharmacotherapy is a good adjunct to use?
Then it again depends on BMI. If the BMI is again, so what I do in my clinical practice is if the BMI is below 35, so I'm not treating only morbid obesity. So there are complications related to obesity like recurrent hernias, varicose veins, and back pain, knee pains and all that. So if BMI is below 35, definitely drugs. If BMI is between 35 to 38, sleeve, and if BMI is above 40, then MGB or Roux-en-Y, even if it's a redo surgery.
Fantastic. I'd like to emphasize on one point he really made, which you should take is we need to treat the patient as a whole, not only the obesity. He said whatever other conditions are there needs to be addressed as well. Fantastic. Let's look at this patient. This is a patient with a BMI more than 60, 160 kgs, was visiting our ICU in the COVID times with obstructive sleep apnea on CPAP machine, repeatedly counseled for bariatric surgery. Post-COVID pandemic, when the work from house changed to work from office, he realized he needs to do something. And for the audience here, just wanted to focus on the video here. This is a robotic stapler device, the Sureform staplers. And just look at it. Is anything happening? So just look at it. I'll come to the point in a minute. So if you look at it, and I'll show you another stapling part as well, the entire thing doesn't shake. It is very still. The Sureform staplers have an inbuilt AI sense which looks at the tissue thickness, tissue fluid. It clamps the entire length of the stapler, and there is a yellow sign which is going, and then the blue firing happens. The yellow sign is it is ready to fire, the tissue is compressed, and the thickness is measured, and then it happens. And this stapling part is not in the control of the surgeon. We can only place it. The stapling part is sensed by the AI, and that's why it is slightly more beneficial than in the laparoscopy, where we are trying to hold the stapler, ask the nurse to hold the gun. We are trying to hold both the hands, turn this side, and then make a crunch sound, and we fear whether it's really fired or not. So there are definitely advantages as we move forward with technology. So this is one point I wanted to highlight, particularly with the robotic stapling device, especially in obese patients in bariatric surgical cases. So quickly moving forward in the interest of time, so we saw the stapling part. Let's look at one last slide. So we are comparing a lot of options for the patients, right from diet, exercise, pharmacotherapy. We talked about endoscopic procedures. We talked about intragastric balloon. We talked about the entire range of bariatric surgery. Dr. Sanjeev, I just want him to make a point. Dr. Sanjeev has done his fellowship in bariatric surgery from GEM Hospital and is now currently working in Fortis Hospital. What do you see in the future trends that you have seen in that hospital, and what are the future things that you feel may help apart from what we have shown here?
Yes, so the routine surgeries, the three main surgeries that were generally being done from the last few years were sleeve gastrectomy, mini gastric bypass, and Roux-en-Y gastric bypasses. So all of this comes with its own set of weight loss results, the excess weight loss, and also, of course, complications. Coming to sleeve gastrectomy, as Wasim sir said, there's a significant chunk of people who do end up gaining weight. That is probably around 20% over a matter of 10 years. So how do we deal with this? Either we put them on OMMs, that is GLP-1 or GIP-1 analogs, or we do a revision. Okay. So what revision can we do for a sleeve? Probably one of the sleeve plus procedures, which is gaining a lot of prominence nowadays. So one issue with sleeve also is GERD. A lot of patients, it's around 30 to 40% after sleeve gastrectomy. So what we can do is connect a loop of probably the small intestine. It might help with relieving the high pressure system that is there in the sleeve, and also maintaining the continuity of the duodenum, sir, which also helps to give access to the biliary system, which is not there in the MGB and RYGB. So that is also another issue that can crop up sometimes.
Fantastic. Thank you for making that point. Quickly, I just want to recap a few things. If a patient comes saying, I am engaged, I want to lose weight before marriage, and she has a 6-month timeline, there is a different choices that we can offer her. If there is a patient who's been sent by the orthopedic surgeon saying, I can't do a knee replacement until you lose weight, we need to counsel them appropriately. Then there is a patient who has a BMI of 60 plus on CPAP, struggling for his breath. So we need to customize and select the patients appropriately, and there is a range of solutions available. But yeah, we need to give them the counseling, education, and bring their expectation to match what we can offer, so that there is no mismatch. And in this particular comparison of weight loss interventions between semaglutide, sleeve gastrectomy, intragastric balloon, I just like to highlight one important point. The last one, if you want weight loss for days or weeks, diet and exercise is a good option. If you want weeks and months, injection is a good option. If you want a few more months, maybe gastric balloon is a good option. If you're looking at long term, 5 years, 3 years, 8 years kind of a weight loss, then bariatric surgery scores definitely better. Thank you all for being, okay, last
Just
comment
want
by
to add-
Dr. Shalini.
I think
She
it
is the
will-
only physician in this entire crowd of surgeons. We owe it to her. Yes, please.
I think everything can go hand in hand. Lifestyle intervention, we can help you, a patient lose weight before surgery, we can help you after
Absolutely,
surgery. So it's
absolutely.
a continuum, it's not lifestyle versus medicine versus, I think this is the precision obesity medicine. I think we can work hand in hand, and absolutely fantastic time to practice obesity medicine.
Fantastic, and that's good to have an ecosystem like us that we have in Fortis. Thank you all for your kind attention. We will move on to the next session in the interest of time. Thank you.
Thank you.
Thank you, Dr. Joshi. I'd like to invite Dr. Saurav Mishra for the next session, which is about the colorectal symposium featuring a video presentation. So may I request Dr. Saurav Mishra to be here? Thank you, sir. Sorry. So the chairpersons for the next symposium are Dr. Rajesh BM, consultant gastroenterology, gastrosurgery and robotic surgery, Fortis BG Road, and Dr. Sharat Chandra, consultant surgical oncology, Fortis BG Road.
Hi, good evening again. Uh, for an oncological procedure, the oncology clearance is only about halfway, half the battle won. Presently, patients want much more than that. Patient wants a good urology control, they want a good sex life, and that means a lot of precision. Colorectal surgery per se can be either benign surgeries or cancer surgeries. So it's a very long topic. So I've chosen just one part of it, which is a robotic colorectal right hemicolectomy, and about 12 steps so that we can have a better outcome. Now, the reason why this is chosen, because this is a wonderful surgery and you get a wonderful outcome if you are doing it properly robotically. The problem with robotic platform is that once you have chosen the patient position, it cannot be changed. So everything what you have to do is you have to do beforehand. And to make sure that you are well prepared going into the surgery, much before docking, you have to make sure that you do your homework well. So usually the patient is supine. Either you can have a head-low position or a supine position without any table tilt. A 10-degree tilt, the right-up tilt could be beneficial, because that would push all your small intestine towards the left quadrant. Now, the instruments would usually be fenestrated bipolar camera, the scissor, the tip-up grasper, which is extremely useful, and a assistant port, which is about 10 mm or 12 mm. The position of the trocars could be in the same layer. This is the standard Da Vinci XI platform, where you have the ports positioned exactly in the same line. You can have a assistant port either between the arm 3 and 4 or arm 2 and 3, and the third port is always 12 mm, because that's where your sure form staple will come in. This is perhaps the best configuration you can have. Usually the patients are, if the patient are smaller, you'll have less real estate available for you to place your port. So you have to be a little more generous coming towards the midline than towards the lateral side, towards the left side. So this is a small video. So this was the patient who was initially operated for a mucinous appendicectomy and found to have appendicular low-grade mucinous neoplasm, and this is we had taken her up for completion surgery. This is the debulking surgery along with peritonectomy and a high pec. So you can see the first step is to get your small intestine out of the way and push the omentum up in the quadrant so it's no more available to you. Second thing is to identify the ileocolic vessel, and this ileocolic vessel lies just adjacent to the duodenum. The duodenum usually is visible even in very patients who are quite obese. The visualization that you usually get with the robotic platform right up to is in skeletonizing the vessel is extremely beneficial, because that's where the whole clearance you would take, and then you go the dissection is always from medial to lateral. You can do a lateral to medial too, but oncologically principles mandate that most of the time you do it from medial to lateral. And the first thing is to get control of the pedicle. Once you have isolated the pedicle, you can directly use the vessel sealer, or probably use a staple, a clip, and then use a vessel sealer, or just use 2 clips and cut it off. I am a surgeon who is a little scared, so I use a vessel sealer along with a clip. A lot of surgeons don't do that anymore. So now the next part of the surgery would be to just go hug the duodenum and try to reach to the right colon. So this plate is easy to form, easy to find. You just need to keep sweeping the retroperitoneum away from your plane, and you will keep on finding this bloodless plane that is the ideal. Now the reason why you should be doing it is multiple reasons. You will get the best clearance that you would want in a oncology surgery. So having achieved the plane here, you can see the duodenum, which is kind of doing the peristalsis there. The idea is to just sweep the retroperitoneal structures away from the right colon. Occasionally, you can use the vessel sealer, which comes very handy. The idea is that you should not have tissue staining. The more tissue staining you have, the more likely that you are going to go into multiple planes and you're going to lose the way. A very tiny, you can see this. This is one gauze piece that I have got, and that is the only gauze piece that I have used throughout the surgery. As you achieve that fine plane, you will find that you have reached the colon, and then you start dissecting from the medial end. And that is where the medial plane and the lateral plane will meet. That is where you know that it's a correct plane. Medial plane, again, you don't have much of bleeding because the line of Toll is there, which you will find quite easily with the robotic platform. The vessel sealer is a wonderful device, although it costs about 30,000-40,000 rupees. But believe me, a patient who is affording about 5 lakhs of surgery would be able to afford this. The next step is to reach your small intestine. You divide the mesentery so that you understand where you're going to be dividing your small intestine. The same thing for the upper margin. The distal end of the colon is dissected. The fat around this, before you divide, to make sure that you divide the colon, you skeletonize the colon from all the fat and the structures around it. This is an extremely important step. It takes a little time to do, but that is where you can sleep well, because all the staples are going to be on your colon. So you can see we have decided that this is the place we are going to divide. It's about 10 to 12 centimeters away from the divided appendix. Now you can see how beautifully the ICG lightens up the place where we have decided to divide the colon. I am very sure about my vascularity at this point of time. This is one of the most exultating moments when you have dissected everything and you ask your anesthetist to inject ICG and it lights up, because that's where you are sure that your other anastomosis, the ileocolic anastomosis, is going to be just fine. So this is where we have divided the colon. The next step is to divide the ileum, and that is about 6 to 10 centimeters away from the ileocolic region. Again, we use the ICG very generously and ask the anesthetist to give a bolus of ICG just as the time we are about to apply the staples. These staples are always sure form, and this will give us a very nice idea about the vascularity. The other thing is one of the most important thing is to get the specimen away from your field. So you have to put this specimen above the liver so that it doesn't come into your picture again and again. You decide where you're going to do ileocolic anastomosis. It is usually about 8 centimeters from the division of your colon and about 2 centimeters away from the staple line in your ileum. Again, these sure form staples are extremely useful. Now, one of the things that we have seen over these years that makes a huge amount of difference in the patient recovery is the intracorporeal anastomosis. We always do an intracorporeal. We never take the specimen out and do it. The reason is that the moment you try to do that, what happens is you have to give something like a mini laparotomy, and that is where it really pains. Those are the patients which actually will recover later on. Comparatively, the patients where you have done an intracorporeal anastomosis and basically done the whole procedures robotically, your patients are going to be much more comfortable than the patients who have had an anastomosis outside. We were doing it in the past like that, but now we have completely converted into intracorporeal. Now the final thing is to get your mesentery sutured so that there is no more internal herniation, and give a nice wash. Sometimes we put in a drain. Most of the time it's useless. Usually it really doesn't give us any desired results. So we have stopped putting any kind of drains, and we use a wound protector to remove the specimen. Now this is the size of the specimen that we were able to remove. The whole procedure took about 3.5 to 4 hours. Later on, we did the peritronectomy as well, and did a resection of the omentum. That took another 1.5 hours. So the whole procedure was done about in 5 hours. Dr. Sharad Chand was with me. He took care of the high-pack part of it, and the whole procedure from the start to end was about 7 hours. So right hemicolectomy is a very effective and safe procedure. It is one of the most easiest to start if you want to do to robotic colorectal surgery. You should usually have a mentor with you that would get your frustration down. And there are steps, if you follow that, you'll be really thanking yourself, because then your whole team is very happy. You have no shouting, no moments in which you are angry, because you know exactly what's going on. Your whole team knows what exactly is going on. So I would suggest that you do it in steps and get a mentor. Thank you.
Thank you, sir. Dr. Saurabh Mishra. That was a wonderful demonstration of the surgical video of radical right hemicolectomy. So we will also discuss about how you would have done a lot of laparoscopic right hemicolectomies as well.
Yes,
So how do you feel that the robo is better or not better? Like, can you explain that?
Yeah, one of the key features that I found that between the robotic platform and this is at the end of the surgery, how I felt. I didn't feel anything, because after this procedure, we had another procedure that we did. It's a bilateral inguinal hernia robotically we did. And I was pretty happy doing it. Believe me, if there was a right hemicolectomy laparoscopically, I've not done too many of them, but I would be done for the day, because the angles and then all this standing for long time, your assistants are angry. Here your assistant is sitting quietly, the camera is with you, you are sitting there, you have gone for a piss break. So these things keep happening, and absolutely
yeah, because
no
I was
problem.
there for the surgery. I was surprised you were going for another bilateral inguinal hernia.
Yeah.
That too again robotic.
So I was just talking about the other time someone was saying about that your robo would be lying there without any use, and you ask all my colleagues would know that how much fights we have for a robo slot. Both of my colleagues are here, and the robo surgery is packed from morning to evening every day. What do you say, sir? We have never seen a day in which there is a robo lying and not being used by any department. And there we have 2 robos. So things are rapidly changing.
Sir, my question is about your port positions.
Yes, sir.
It appears more towards midline. Do you follow the same port position for all your cases, or you depending on the patient?
It's actually in the oblique line, sir. The problem with the Indian patient, whatever we have seen, all the videos and available online, and see what we see is in European patients whose abdomen is quite big. So you can do this obliquely, which is more desirable in these patients. But Indian patients are smaller, the abdomen cavity is smaller, so you have a lot of crowding here if you go laterally. If you go in the midline, you will have slightly more real estate, because your first position, fourth port would be near the epigastric port, which is near the ninth rib.
Sir, another advantage that I noticed when we did laparoscopic hemicolectomy versus robotic hemicolectomy, when you are doing that retroperitoneal dissection, you can actually go very close to the point of dissection, which generally the laparoscopic camera, you are at little distance away from the exact point of dissection, whereas with robo, you can actually go there and see the fine fibers of that areolar tissue, and you can find the correct plane of dissection.
Yeah, absolutely.
And another point with respect to the usage of ICG that I would like to clarify, this is basically to confirm the adequacy of vascularity for the anastomotic areas. So not with respect to GI surgeries, when we did some head and neck surgery reconstructions, we have used it for certain flaps like a deltopectoral flap to see the tip of the flap, whether the ICG is reaching the tip of flap or not. In spite of having good ICG circulation or lighting, the tip lighting up on the green color, we had certain flaps failing after the surgery. Then we thought what is happening. Then we realized ICG only assesses the arterial inflow. It doesn't assess the venous drainage adequately. It is not as good in assessing the venous drainage as it is with respect to the
Yeah.
assessment of arterial inflow. So of course, anyway, we keep adequate amount of mesenteric bulk at the anastomotic site.
Correct.
So this point I just wanted to mention.
Yes, I totally agree, sir. Nothing is 100%, but at least
Yes,
you
yes.
I
That's
mean,
why
you can
experience
reach about
scores over
99%.
technology.
Yes.
Any questions from the audience?
Thank you, sir.
If there are no questions, we'll wind up the session. Thank you.
Thank you.
Dr. Amit, Consultant GI Surgeon, Sakrawald Hospital. Dr. Balakrishna, Consultant GI Surgeon, Manipal Hospital. Dr. Rajesh BM, Consultant GI Surgeon, Fortis. Dr. Adarsh, Consultant Medgastro, BGS Gleneagles. Dr. Chetan, Consultant Medical Gastroenterology, Fortis Hospital. Please welcome them with a warm round of applause.
Good evening, everyone. I'll try to keep it as short as possible. Okay. Oh, separate laptop. So let us try to understand. Bartilla. Full screen ಮಾಡಿದೆ. So let us try to understand, does robotic surgery really help with pancreatic procedures? So I have two case capsules. I'll keep it as brief as possible. One is about robotic distal pancreatosplenectomy. A 50-year-old lady presented with severe pain in the abdomen, required IV analgesics, no history of fever or jaundice. So blood investigation wise, essentially it was a normal study. Coming to the scan, there was a cyst sitting in near the tail of pancreas of size of about 5 into 5, 5 into 5 centimeters. So we did an endoscopic ultrasound in this patient. Mucin was CA levels were quite high, suggestive of a mucinous cystic neoplasm of pancreas. PET CT was done, suggestive of low-grade uptake tumor at the tail of the pancreas. So we went ahead and did a robotic distal pancreatosplenectomy in this patient. So first we open up the gastrocolic ligament. So as we can appreciate the vision, as Sir was telling, we can easily see the strands. So the tissue, the plane where we are supposed to enter. So that's why supposedly the lymph node yield is better with robotic procedures. So now we are dissecting the lymph node along the splenic artery. As can be seen, the plane is easily made out with the robotic system. So slowly, after dissection, the lymph node clearance has been achieved. So then we start dissecting the splenic artery. So we can go as close as possible to the artery in dissecting the lymphatics. So after dissection, so we'll be clipping the splenic artery. So as can be seen, the splenic artery has been completely bared of the lymph nodes. So then we create a window inferior to the splenic artery. And we are ligating splenic artery. So then we go to the inferior aspect of the pancreas and try to identify the splenic vein. So the vision is second to none. So as can be seen, so the clarity is too good. This is a 2D capture of a 3D visualization that we'll be seeing at the console. So we can imagine that the surgeon would be seeing a much better picture than what we are seeing actually here. The splenic vein has been isolated, it's been ligated. So now that pancreas has been freed from splenic artery and vein, we create a window and stapler it. So we are using a robotic stapler there. So we are transecting the pancreas. So there was mild bleeding in this region, so we sutured it. So then once pancreas is transected, so we slowly go in the retroperitoneal region anterior to the gyrotas fascia. Since we were not suspecting malignancy in this patient, we are not going posterior rams, we are going anterior. So rest all is, we have to dissect pancreas from the posterior retroperitoneum. The spleen has been lifted up after dividing the splenocolic ligament. So the plane is easily seen with the robotic system. So that is one advantage we always have. See, so if your plane is right, the bleeding is also less. The procedure is completed, we bag and we took it out. So post-operative course in this patient was uneventful. Video So post-operative period was uneventful in this patient. Biopsy was suggestive of mucinous cystic neoplasm of the pancreas. So this is a specimen that's been retrieved and hardly can we see any scar in the patient's abdomen. This was in post-operative day after 2 weeks. So that was about robotic distal pancreatectomy. Then coming to robotic Whipples. So a 70-year-old lady presented with jaundice of 3 months duration. So initially seen by a medical gastroenterologist. The patient was frail, her ECOG state was not very good, so they tried to do palliative management in the patient. So they didn't offer surgery to the patient, so they had put a stent. So while doing ERCP, they had taken a biopsy which was suggestive of ampullary adenocarcinoma. So she came back to us after those 3 months of stenting with jaundice, no evidence of cholangitis in the patient. So we decided after counseling with the patient, so we did a CT scan and MRI abdomen, which was suggestive of a bulky ampulla. So this was a CT image showing the double duct sign. So patients and attendants were counseled for the need for surgery, and robotic approach was explained and informed consent was taken. So we went there, we did a robotic Whipples in this patient with FJ. So I'll just demonstrate the resection part. So this is the reconstruction part. So this is the tunnel that's being made. After doing the tunnel, we are resecting the pancreas at the neck region. So this is the duct will be opened. So the patient had a good dilated pancreatic ductal system. It was almost of size of 1 centimeters. So after the pancreatic transection, so uncinate process was dissected. So in this procedure, the robotic system definitely helps with good visibility. So we can see the plane between the uncinate process and the superior mesenteric vein. So dissection is relatively easier as when compared to laparoscopic procedures. After specimen transection, so I'm doing a pancreatojejunostomy. As can be seen, I'm taking that apical stitch between the mucosa of the pancreatic duct and the jejunal mucosa. So I am suturing with my left hand. So while doing laparoscopically, this apical stitch is very, very difficult. To get that angle, it's very difficult. And as we all know, laparoscopically doing suturing with right hand is difficult. We can't even imagine doing it with left hand. So with robot, that is that one advantage. With equal accuracy, we can do a suturing with our left hand. So the incidence of fistula is relatively better as when compared to laparoscopic procedures. So I'm doing that apical. And this is one more thing. So at any angle, we can hold the suture and do the stitching process. As can be seen, I have twisted this angle at a very non-convenient angle so as to say if it were to be done by laparoscopic procedure. So all these final maneuvers can be done easily with robotic system. So this is the completed pancreatojejunostomy. So we did hepaticojejunostomy. Again, the same thing. I'm starting the stitch with my left hand because at that angle, reaching with the right hand is very difficult. So we completed hepaticojejunostomy and gastrojejunostomy. So gastrojejunostomy is relatively straightforward. Even with laparoscopy, it can be easily done. So this is completed hepaticojejunostomy. Then we are doing a gastrojejunostomy in this patient. So this is the patient. So as can be seen, she's frail, elderly patient. Medical gastroenterologist had almost told that this is more of like for a palliative care. A definitive resection cannot be done in this patient was the prevalent idea at that point of time. We operated on this patient, and this patient sitting on the post-operative day 2. She is comfortable. She was started on FJ feeds and discharged on post-op day 8. So biopsy was suggestive of ampullary adenocarcinoma in this patient. So why this comparison matters? So why should we compare laparoscopic procedures with robotic procedures for pancreas? Because pancreas is a very important cause of death. It's the 4th leading cause of death among all the cancer patients. And there has been increasing evidence, and people have been increasingly using robotic-assisted distal pancreatosplenectomy. Initially, it was 30%, now it's become 42%. And as we all know, from since afternoon we have been discussing about this, it provides very good 3D vision, and we have 7 degrees of freedom. So this is the basic anatomy. So the mini invasive. So first, let us try to understand what is the difference between a robotic and a laparoscopic surgery as such, and then we will try to understand whether really does it translate in improving the patient's quality of life post-surgery. So we know about the laparoscopic technique. So we have discussed about this, how better is robot as a tool as when compared to laparoscopic procedures. So this is a table. One second. So this is a table comparing robotic with laparoscopic, just the tools it is. So then coming to the evidence-based medicine, should we consider doing a robotic Whipple's in patient as when compared to a laparoscopic procedure? So when we compare this operative time with conversion, the odds ratio and relative risk ratio favors robotic surgery. In terms of conversion, the operative time, there is not much significant difference, as can be shown in the initial period when we start doing robotic Whipple's. Robotic Whipple's normally takes more time than laparoscopy because the docking, understanding the anatomy and all those things definitely matter. Once everything is streamlined, the timings becomes very much comparable. Blood loss and transfusion, definitely as we can see the vessels in a much better way, robotic has an advantage over laparoscopic procedures. Oncological outcomes and lymph node yield, as we are seeing lymph nodes, the distinction between the vessel and the lymph nodes in a much better way. The lymph node yield is shown to be better, but whether it is significant or not, that's again debatable topic. So coming to the post-operative pancreatic fistula rate, the delayed gastric emptying and the morbidity rate favors robotic, but it's not been shown to be statistically significant. So coming to the learning curve, it's more or less the same. The robotic Whipple's would be requiring around 31.5 cases. Lab would be requiring 35 cases. So summary of the meta-analysis. So if it's were to conversion to open, so many a times we need to convert. So that probability is less with robotic procedures. Then blood loss, lymph node yield and is better with robotic procedures as when compared to the cost part. Again, it favors laparoscopy. So then comes robotic versus laparoscopic distal pancreatosplenectomy. So operative time and blood loss is less with robotic procedures. Operative time more or less it's the same. Robotic distal pancreatosplenectomy takes a bit more time than laparoscopic surgeries, but again, it's not statistically significant. So the main difference that happens between robotic and laparoscopic distal pancreatosplenectomy is in if we are planning to save spleen. When we are trying to save spleen when doing a distal pancreatectomy, So we need to identify individual vessels running from splenic artery and vein to the posterior aspect of the pancreas. So if we have a good magnification with 3D vision, these vessels can be individually ligated and splenic artery and vein can be saved. So the incidence of the possibility of us conserving spleen is statistically better with robotic as when compared to laparoscopic procedures. So post-operative complication and length stay, the complication rate is relatively less with robotic surgery. Length of stay more or less is the same. So 30-day mortality, again, there has not been much significant difference. However, the lymph node yield is a bit better with robotic procedures. So coming to the meta-analysis, the operative time, it favors laparoscopy. Rest all, most of the time, if it's blood loss or if it is conversion to open, spleen preservation, post-op complications and 30-day mortality slightly favors robotic procedures. So cost considerations, higher per cost, as we had discussed previously, if the number increases, number of the procedures being done increases, automatically the cost will be balanced out at some point of time. So international guidelines wise, if it's a benign or pre-malignant lesion, definitely robotic is preferred. Robotic DP with expertise for resectable pancreatic adenocarcinoma is acceptable. Robotic versus laparoscopic, low conversion, higher spleen preservation, definitely conditional recommendation, but it has low evidence. Age, BMI, and prior abdominal surgery, there is no absolute contraindication. Both lap and robotic can be used. So the main issue with all these studies is we don't have a randomized control trial from multi-centers. Most of these are meta-analysis based on retrospective studies. So, and sometimes when we are doing a robotic surgery, when we are starting the robotic program, there will be a case bias wherein we would have selected patients who don't have much of a disease burden or it was a pre-malignant lesion. So most of these things should be taken conditionally and applied individually on the patients. So these data and all make a true sense only when we have RCTs and multi-center trials, which we don't have as of now. So key takeaways, lower conversion to open if we are doing robotic procedures, higher spleen preservation, higher lymph node yield, but again, everything, it has a con that is the higher upfront cost as when compared to laparoscopic procedures. Thank you.
Thanks, Dr. Shashikiran, for that masterclass on robotic pancreatic surgery. Shashi probably forgot to give a disclaimer. Like we see on the mirrors, objects can appear closer than what they are. Surgery can seem easier with what Shashi does. Please don't try this in your OTs. Couple of questions. How did you how was your transition from a laparoscopic surgeon? I have seen you do laparoscopic Whipples as well. So how was it different? How is robotic Whipples different from laparoscopic Whipples? My first question. And how do you select your patients?
So basically, it takes time. So it's not easy. So especially for us, general and surgical gastroenterologists, we are very well trained in laparoscopic surgery by this time. As when compared to urologists or gynecologists, their leap would be, most of the times it would be open surgery, and directly they would go to robotic surgery as such. So they don't have this pit stop of laparoscopic surgery, which we would have learned after putting in some 10-15 years of our life, learning so much, putting in so much and learning the laparoscopic skills, and then suddenly robot is there. So you take your time, and sometimes you might have to unlearn a bit. For example, I'm doing robotic surgery and next time I'm doing a laparoscopic surgery. I'm getting irritated on my person who's showing the camera because I am used to robotic surgery with me showing camera to myself. So when some other person is showing that camera, again, you have to make that shift. So that initial hesitation, that initial irritation will be there. Only thing is, if you really want to do it, you can do it. And if you keep doing it, there are pit stops here. So first 20 cases, you're irritated the most. So why am I doing this? Laparoscopy, I would have finished off in 15 minutes, I would have gone home. So that thing will always stay will be playing in your mind. So once you do 50 cases, you're getting comfortable. Once you do 100 cases, 200 cases, then you start understanding, yes, robot is actually better than laparoscopy. At the end of the day, you are less tired than what you would be if you were doing laparoscopic procedures. So after you complete some 200, 250 cases, then you are sure ki, yes, robotic is the way forward, and definitely, robotic definitely helps. And most important thing about robotic surgery is the team. Because when you are operating, sitting at the surgeon's console, an equally good surgeon should be sitting by patient side. If there is a bleeding and if your whole field is gone, then you are done. Because in laparoscopy, you are there by patient side, you can do the suction, you can control it. But if the person who is sitting beside the patient, if he is not well equipped in assisting you, then it's a mess. So robotic surgery requires a very good team. While I was doing robotic Whipples, and another consultant who is equal to me was assisting me at the patient bedside. So it cannot be a senior resident who is assisting sometimes. If it's a major case, You need an equally experienced surgeon sitting by side. As I told you, it's a teamwork, so it cannot happen individually. But if you persist, definitely you'll reap the benefits and you'll start realizing the advantages of robotic surgery. It's just that you have to give in some time there, that's all. So initially, to start with, if we are starting the robotic program and you're well versed with laparoscopic procedures, as the recommendation says, it should be a simple pre-malignant lesion or a lesion with not much of disease burden, not much of lymph nodes, not infiltrating major organ like that.
Essentially, you should not select a vascular tumor which is involving the vascular structures in your initial few cases.
In the initial few cases to start with, if you have very good assistant by bedside, definitely you can go ahead once you are think you are capable enough, and that only the surgeon who is choosing that patient can decide, because he knows his own capabilities.
Any questions from yours? Can we wind up, Shashi? Thank you.
Thank you, Dr. Shashikiran, for your expertise and surgical experience. As we conclude today's scientific sessions, we end with a topic encountered by every GI surgeon, that is GERD. So, may I request Dr. Manish Joshi to deliver the concluding lecture on GERD and recent advances. I also request our respected chairpersons to kindly take the stage, Dr. Wasim, Dr. Sanjeev Shetty, Dr. Harish, Dr. Chetan, and Dr. Shalini Joshi. Thank you.
Do you have a mic? Okay, fantastic. Dr. Chetan is a consultant medical gastroenterologist. Would you want to highlight the burden of GERD cases? How many cases do you see on a daily, weekly, monthly basis? Numbers, just rough numbers.
So at least 30% is GERD, roughly.
So 30% of what denominator? How many cases do you see in a...
Other than excluding liver and pancreas, if we take only luminal cases, upper lumen, especially esophagus, peptic ulcer disease, and GERD will be significantly, we'll see. If we go for large intestine smaller, where we'll see IBS kind of things. So roughly if we take 4 guts, I will see GERD roughly around 30%.
Okay. Dr. Harish, how many endoscopies are you doing in your center?
Yeah. So each day around 2 to 3 endoscopies. So most of my burden is GERD only. Yeah. GERD and H. pylori positive.
Okay, Dr. Shalini, in your practice as a physician, how do you differentiate acid peptic disease versus, more importantly, cardiac issues?
So basically, any new severe pain, depending upon what is the patient age and risk stratification, every case first has to be ruled out for the cardiovasculars, and definitely if it is a 25-year-old with a clear-cut GI symptoms, absolutely you can go ahead and treat, but always rule out the cardiac with some ECG markers, and then you can go ahead and treat. And if you see any alarming symptoms like odynophagia, any bleeding, any anemia in an elderly person, any bolus-like symptom, I mean, definitely you have to refer to the GI for evaluation for any alarming symptom.
Fantastic. Just going to go through a short video and throw questions and talk about dilemmas in managing chronic GERD. How many of you have issues managing GERD patients in your practice? Of course, Dr. Chetan has raised his hand, and let's look at options available as well as the dilemmas as well. So, which of these patients, Dr. Chetan, you will be more worried if he comes with atypical chest pain or some symptom which is not classical? And more importantly, I wanted to ask the classical symptoms of GERD, heartburn, regurgitation, is it the common ones, or you see patients with different kind of symptoms as well?
Predominantly most of our referred cases already classical symptoms, we do see heartburn and thing, and most of the time it is referred also where we will have extraesophageal symptoms like persistent cough or sometimes atypical chest pain. Most of the times it's referred from ERT where they see LPRD and they refer to us, or it's like a globus pharyngeus where they have a foreign body sensation. Typical, we do see the chest pain and heartburn things, but I would be concerned about if the elderly patient where you'll have atypical chest pain.
Okay, I think the audio is not there. Maybe I'll have to switch it on. But fine. What is the what is the 2 or 3 symptoms that you find in your practice where you feel it is GRD and not cardiac issue?
One is heartburn.
Heartburn.
That is most of the time, and I also look into whether it is an elderly patient diabetic, where even if it is it looks like straightforward GRD, I always think it's first I'll always look for ECG.
Okay.
Or if there is exertional symptoms, then I'll always evaluate cardiac, even though it looks for me straightforward, elderly and diabetic. Otherwise, as a young patient, no other risk factors. If there is a heartburn, chest pain, and globus, these are the things we usually see, and rarely it's like a cough. That is one thing.
Okay, fantastic. Dr. Shalini, what usually is the lifestyle modifications that you advise to a patient who comes to you?
Yeah, so lifestyle modification, first and foremost is eat your food on time. Anybody who has more nocturnal symptoms, but otherwise also early dinner, have a gap of 3 hours. If there's symptoms chronic, 30 degrees elevation of the head end, exercise and try to cook yourself and don't order food on the apps.
Fantastic question. Harish, what would be your first line of management? A patient comes to you with acid peptic disease. Apart from lifestyle modifications, what would be your way of treating the patient?
Yeah, mainly the diet counseling and the lifestyle changes, and the PPI we start. So for a period of around 2 to 3 weeks. So based on this recurrence, so we have to treat aggressively.
Fantastic. I'm just highlighting this picture because this is the range of patients that we get, and these are all patients whom we have done anti-reflux procedures. The youngest one is 17 years and the eldest one is around 92 years. And everybody has a different reason. Some patients have Barrett's esophagus, somebody has I'm fed up of not eating normal diet kind of symptom, and somebody, the 17-year-old has been there for 3 years on medications and he's not able to concentrate on his exams and do well in the studies. So different reasons, different expectations, just trying to highlight and probably move on to what we find in an endoscopy. Dr. Chetan, do you want to take that question? When somebody is asking for an endoscopy or you are requesting an endoscopy, what are the things that you are looking at basically which will make the endoscopy valuable in your management?
So especially if I am going in for all the patients, endoscopy prior indication will know, especially GRD for me, where is the G junction, where is the Z line, what is the Hill's criteria. These are the things we look. And also for grading of GRD and Barrett's, if these are the things which most importantly I'll look into.
Okay. From a surgical perspective, what are you looking at, Harish? Anything different?
Yeah, so most of the time, the resistant patients with PPI, we consider a surgery. So I look into the hiatus hernia, the grading of the hiatus hernia. That's the most important factor to consider as a patient for the surgical candidate.
Okay. And
types of hiatus hernia and grading of the hiatus hernia.
Chetan, again back to you. H. pylori, how much is the prevalence? And we know that it is all commonly prevalent. When do you choose to treat a patient with H. pylori eradication treatment?
One is H. pylori because it is in India, even though we see a lot of H. pylori, there is a confusion whether should we treat all H. pylori positive. But because we know H. pylori, it's like long term they may develop a malignancy. If you don't treat, you will end up in a suit. If you see positive, you treat it. Whether it's right or wrong, that is second thing. Second thing is, previously when we used to do rapid urease, older one, we used to see a lot of positivity. Newer kit, it has come down. We don't know whether because already they have taken some PPI. Or
okay.
The older kit was a lot more.
Yeah, can we move to Dr. Shalini? There are newer molecules which are now available apart from pantoprazole and the prozols, the vonoprazole and similar molecules. How frequently are you using it, and what has been the response with the patients?
So basically, as the other my colleagues told, that PPI trial for 8 weeks is warranted. If the patient has a very severe esophagitis or is not responding, in that case is refractory to PPIs, only in that case you can use the PCAB, the vonoprazole. It should not be used as a first-line therapy. PPIs are still the first-line therapy, and there's no level 1 evidence to show that they are really causing any vitamin B12 deficiency and gastric cancer. There's some observational studies, the association, so it is not proved
Sure.
yet.
Dr. Chetan, this one is for you on grading of hiatus hernia on endoscopy.
Yes,
Which one
will you refer?
Which one will you refer is the question which he is saying, which is very sweet to the ears of all the surgeons. But how and where do you look at the grading? And the first type 1, grade 1 and grade 2, what do you do?
Grade 1 and grade 2. We have seen grade 3 and grade 4 also. Sometimes they may not have a significant symptoms, especially elderly and all. Sometimes grade 1 we rarely see significant symptoms. Grade 2 is a very tricky situation. Sometimes they will have significant symptoms. You always look into, if there is grade C, grade D, even in grade 2, we'll definitely have to look into that. So
Okay, so interesting question I wanted to ask you again. At this time I'll ask you. There are patients with symptoms but normal findings on endoscopy, and there are patients without symptoms. when we remember the image, is patient's preference. Patient goes on 6 years, 10 years of medication, at some point says, I want something better than what I am going through quality of life, then it is definitely an option that can be considered. So patient preference is at the topmost, along with the other indications which we can recommend. There are a couple of options in anti-reflux procedures. There's endoscopic options and then there is surgical options. Endoscopic options, Chetan, Strata, SURGX, Lynx, Arma.
Personally, in our center, we are not doing this. We feel in long term it's always better.
So, an endoscopy, who does the endoscopy, diagnoses a particular grade 1, grade 2 hiatus hernia. If they want, they can also offer endoscopic procedures like Lynx, SURGX, TIF, Arma, and Strata procedure also. I have done Strata procedures, endoscopic procedures, where there is a radiofrequency ablation given to the lower esophageal sphincter, which is lax, and over a period of 6 to 8 weeks, the heat energy which is given there makes the muscle fibrosed and thickened over a period of 6 to 8 weeks, and it forms an anti-reflux barrier for the acid to go up, and it decreases the episodes of reflux episodes by 70%, which is equivalent to anti-reflux surgery or fundoplication. Sanjeev, anything that you have seen? You've seen laparoscopic fundoplication, robotic fundoplication.
Sir, in case people who are suffering from obesity, then RIGB is a good option. Even by gastric bypass, it will take care of their weight and metabolic issues also, and reflux also will be.
Okay, so let's. So what he's trying to say is, if there's obesity and GERD, then we need to be a bit more careful as to what procedure we are choosing for obesity. We don't want a sleeve gastrectomy because the hiatus hernia will cause a lot of gastric reflux post sleeve gastrectomy. I think we are on. If I can show a last video and then probably close this entire session. In my experience, and again, I'm one of the possible thousands of people doing this procedure. So it is a limited experience, but in my experience, patients who have earned their anti-reflux procedure over a period of years, having tried a lot of things and then come to the surgical option, and if we select the patient right and counsel them well, these are the 3 patients that I had shown, different age group, post surgery, most of them in the first month follow-up and the 3 months follow-up and the 6 months follow-up, they always ask this question, why didn't I get this thing done earlier? Why did I suffer for 6 years? Why did I suffer for 10 years? But this is again a select group of patients where we have to be choosy and they have to go through the entire process to earn their surgery. So let me just see if there is anything. So this is the Strata procedure. You can see the first image showing the radiofrequency probes. The second image showing the radiofrequency heat waves in the 6 different levels at the lower esophageal sphincter. And the third picture, after 6 to 8 weeks, there's a tightened junction. And I think the video is not working, or it is giving us a sign that we should close it. Let me see. So again, robotic surgery has been highlighted that suturing is the most easiest. We find it very good for the hiatus part as well and for the pelvic part as well. I think we'll quickly move on. Otherwise, the food is also going to get cold and we are going to get leftovers. Right. Any questions on GERD? I'll throw it open to the panelists and to the audience here while we run the video.
Do you do esophageal manometry prior to surgery for all the patients? If you're planning
Good
for
question. Harish, you want to answer that?
Yeah, we do esophageal manometry. So only once the esophageal manometry shows there's a significant acid reflux, then we consider for the surgery. So one of the primary investigation. Based on that, we consider surgery.
I would, for all surgeons, I request to do manometry personally because there will be motility problems, especially if there is a complete absence of motility. You end up doing 360-degree fundoplication. They'll come up with a dysphagia. At least then you can plan for partial. So at least, because we have seen referred cases from elsewhere where they have done 360 and come up with a dysphagia. So then you can plan for at least partial.
Manometry is definitely a recommended pre-operative option to be done in all patients. However, what I realize is most of the patients are very unhappy about the cost and getting another procedure done. So we send them to you, but probably we see only few of them getting it done, not all of them. Just a thought. So this is one RCT NEGM in 2019 where they had done a RCT about medical versus surgical treatment for refractory heartburn. So we have talked about refractory medical treatment, we have talked about hiatus hernia, and specifically we were not very convinced whether apart from hiatus hernia should we offer surgery for patients with refractory heartburn, and this RCT has clearly showed that surgery definitely helps. 67% improvement versus in active medical treatment it's only 28%. So this is just the evidence that has come up and this is made easier for us to offer anti-reflux procedures for refractory heartburn or patients on long-term acid peptic disease treatment. Can I call the team here please on stage, whoever is available. Thank you all the panelists, all the audience for staying back. Please have dinner. I want all the team, whoever is here, or we can just have a round of applause for the team behind this entire thing. Dr. Diksha, Dr. Purna, Dr. Rajesh, Dr. Sanjeev, Dr. Shashi. Anybody else? Everybody has left. Dr. Ganesh, is he there? I can't see him. Fair enough, fair enough. Just wanted to acknowledge that it is teamwork, it is not a single person. Maybe a single person is the face of the organization or the department, but the entire team, the OPD nurses, the OT nurses, the surgical team, including the counselor, everybody is important in getting a patient into the ecosystem, getting a good experience and a good outcome. Thank you everyone for the kind attention and for being here.
Yeah, so it's a beautiful evening. I think just 4 hours is a packed scientific session. I think it's a great experience. So we got something more out of it. Thank you so much for the entire team. I congratulate the Fortis and the team headed by Manish Joshi. Thank you.
I congratulate Manish team and entire Fortis on behalf of Surgical Society for giving a wonderful session on entire gastroenterology work and successful robotic surgeries history, story. So I congratulate entire robotic team and entire Fortis, all administrators who helped Manish to get such a good feast. Thank you so much. Thank you.
Thank you. Thank you for the kind words. Can we have a group photo, please? Whoever is there, join us on the stage, please, please, please. Come, come, come. Yes, sir. Please come. Please come. Please come. Join. Basiraj, you can join. Dr. Purna, you can join.